Good evening, Sisev madam.
Good evening,
Ramesh sir. Sharma sir, good evening.
Good evening, ma'am. Good evening, sir.
Good evening, Dr. Lakshmi.
How are you, sir?
Great. I'll just put my video on.
Sir, home shelter restriction కావాలి. So there is need to go to amount of
Good evening, Ramesh sir.
Good evening. How are you?
Good evening, sir.
How are you, Dr. Chaudhary?
Good evening, sir.
Good evening.
Good evening, Durga ji.
Good evening, ma'am.
How are you?
Good evening, sir. Dr. Ramesh sir and Dr. Chaudhary sir, good evening.
Good evening to everybody. Good evening.
I think Dr. Naliappa sir didn't join till now.
Ma'am, good evening. I'm here
Sir,
only.
where, sir? Good evening. How are you?
I'm ready, ma'am.
Are you switch on your video, sir?
Yes, I'm switching on. Settings. Number 10. Settings. Take it.
Dr. Dr. Nandini and Janathan join?
Yes, ma'am. Good evening, ma'am. Good evening.
Yeah, good evening. All the best.
Good evening, ma'am.
Thank you, ma'am.
It's 4 o'clock. Shall we start, sir?
Yes, madam. Dr. Sridevi here. Good evening, madam.
Good evening.
Good evening, ma'am.
Rohit,
Good evening, ma'am.
we'll start.
I would like to welcome all the students and the faculty for the Apsicon 24 Plastiquest Prelim Session 5. Today we are going to have case presentation by
Yes.
Dean
Good evening,
Delhi
ma'am.
on a case of postbone contracture neck. Now I'd like to request Dr. Lakshmi ma'am to welcome the gathering.
Good evening, everyone. I welcome our patron, Dr. V. Bhattacharya sir, and overseas faculty, Dr. B.V. Ratnam Garu, who has sponsored Zoom platform for the Plastiquest, and Apsicon 24 organizers and Plastiquest team and entire Plastiquest family, that is Plastiquest faculty and pages across the country. For today's session, the Apsicon 24 Plastiquest prelims session number 5. You all aware that the Plastiquest Apsicon 24 Plastiquest competitive session is happening for the first time. 16 teams registered for this competition, which we are conducting online as a preliminary rounds. And 2 teams will be selected from these 16 teams, and the finals will be conducted at the time of Apsicon 24. So the judges team will be monitoring all the sessions, and they give analysis at the end of all sessions and select 2 teams. Today we are conducting the 5th session of the preliminary rounds online. So we have 3 panelists for today's session. It is a great pleasure to have all these 4 panelists, very experienced and academicians. It's a great pleasure for me to introduce Dr. Ramesh Kumar Sharma sir. He's a very senior plastic surgeon. Formal introduction Dr. Rohit will do. I am telling you about my association with Dr. Ramesh sir. I have been listening his lectures and attending his teaching programs, excellent teaching programs and academic sessions. I am fortunate enough, I happen to work with him as a member, expert team of NMC in preparing the PG curriculum for plastic surgery PGs all over country, which is uploaded in website, and organizing the APSI CME collaborator labs. It was great pleasure to for accepting to participate and share your experience in our Plastiquest program. I welcome you and remaining
Thank you.
panelists, Dr. Sridevi Madam, Dr. Durga Madam, and Dr. Nalepa sir. They are all my colleagues in other reputed institutes with good friends, good teaching experience, and academicians and dedicated teachers. I invite all of you, and now I request Rohit to give the formal introduction so that the all postgraduates will know their work for our plastic surgery.
Thank you so much, ma'am. It's my privilege to introduce these four esteemed panelists for today's session. Initially, I would like to welcome Dr. R.K. Sharma, sir. Sir is right now working as Director of Plastic Surgery, Paras Hospital, Panchkula, Haryana. Sir previously worked as a Dean, PGI Chandigarh, and HOD of Plastic Surgery from 2002 to 2022. And he has 227 peer-reviewed publications with 2,362 citations. Sir is a trustee for APSI and also president of APSI and president of Indian Society of Cleft Lip, Palate and Craniofacial Anomalies, and president North Zone Association of Plastic Surgeons of India, and regional faculty of AOCMF Switzerland, and member expert group of NMC for plastic surgery and aesthetic surgery curriculum. And he trained about 200 plastic surgeons till date. We welcome you, sir. Thank you for gracing this occasion.
Thank you.
Now I would like to introduce our second panelist, Dr. S. Sridevi ma'am. She is consultant plastic surgeon and professor, head of the department, Stanley Medical College, Chennai. Ma'am completed her MBBS in 1998 at Tirunelveli Medical College. She came out of as best outgoing student of the year in 1988, and she completed her MS at Stanley Medical College, Chennai, and MCH Plastic Surgery from Madras Medical College, Chennai. She has vast 25 years of experience in plastic surgery. She's been expert teacher for postgraduates in plastic surgery since 2000. She has specialized in various subspecialties of plastic surgeries like congenital anomalies, burns, trauma, external genitalia reconstruction, and facial-maxillary trauma, hand and microvascular surgery. And she worked in almost all institutes in Chennai, like Madras Medical College, Stanley and Kilpauk Medical College, and Government Raipet Hospital. And she's a member of APSI and Tamil Nadu and Pondicherry Association of Plastic Surgeons Association, and organizing secretary of Tamil Nadu Plastic Surgery Conference, and has been examiner of NB in plastic surgery specialties. We welcome you, ma'am. Next, I would like to introduce our third faculty, Dr. Durga Karki. Ma'am is Director and Professor, Department of Plastic Surgery, Vardhaman Mahavir Medical College and Saptajang Hospital, Delhi. Ma'am has graced many positions in her academic career. She has been Executive Member, Association of APSI, and Executive Member of Indian Society of Peripheral Nerve Surgery, and Executive Member, National Academy of Burns, India, and Executive Member of Indian Society of Surgery of Hand, and Executive Member of Indian Society of Wound Care and Research. She is also a Joint Secretary of NABI, and she has graced with many awards. She got awards of excellence in recognizing of her outstanding contribution in Apsicon 2022, and she got APSI Junior Best Paper Award and Kilner Essay Award and McNeil Award, and University Award for Best MCH Thesis. And she has done multiple fellowship. Few of them are Chem Microsurgery Fellowship and Ethicon Plastic Surgery Traveling Fellowship and Biotech Fellowship in Plastic Surgery and Ethicon Traveling Fellowship in Cosmetic Surgery and Ethicon Microsurgery Traveling Fellowship. We welcome you, ma'am. Thank you so much. Now I am going to introduce
Thank you,
our fourth
Dr.
panelist, Dr. Niliyapar sir. Sir is Professor and HOD, Department of Burns Plastic Surgery, Government Kilpauk Medical College. Sir has done his MBBS from Madurai Medical College and MS from Stanley and MCH from Madras Medical College. Sir was conferred with honorary FRCS by Royal College of Physicians and Surgeons of Glasgow, and he is serving in Tamil Nadu Medical Service for the past 34 years and as a teaching faculty for 26 years. Sir has participated in over 50 national and 7 international conferences, have been guide for 25 thesis topics for MS and MCH postgraduates. Sir has published 8 papers in various reputed journals and presented 15 papers in various conferences. And Sir has been member of various professional bodies like IMI, ASI, APSI, and Diabetic Food Society of India. And Sir has been examiner in Tamil Nadu MJR University for the past 8 years for MCH Plastic Surgery, MCH Hand Surgery, and various fellowship programs, and examiner for MCH at AIIMS New Delhi. And he has been National Board Examiner for DRNB Plastic Surgery. Apart from being HOD of Plastic Surgery, he also graced a few administrative posts like being Deputy Superintendent of Stanley Medical College and Superintendent of Government Roypet Hospital, and also has organized various academic programs through IMA, ASA, and APSI, and have been received District Collector Award twice and IMA State Award and Dean's Award, apart from other awards from Culture and Social Organization. We welcome you, sir. Thank you so much, sir.
I welcome all the 4 panelists for today's session.
Now, before going to the session, I would like to give a roll call for all the PGs. Hello.
अभी तो बेटे भेजा नहीं है, भेजेगा मैं तेरे को बता दूंगा। कोई उनको कह दो, कोई बात नहीं, मंडे को दे देंगे, इतनी जल्दी नहीं है, मंडे को नहीं भी मिलता कोई।
Hello. Madam. Madam, shall I proceed with the roll call?
Yeah. Please take roll call for all the teams.
Okay. Now team 1, Madras Medical College. Please respond. Anyone
Yes,
from?
sir. Present, sir.
Switch on your video.
Switch on your video, please.
Yes,
Oh,
sir.
Lisa. Okay,
Present,
fine.
sir.
And team 2 from Jipmar Pondicherry.
Present, sir. Present, sir.
Okay, Bharat Kumar, fine.
Yes.
And team 3, KGMC Lucknow.
Present, sir.
Okay, Srinivas Mishra. Okay, fine. Stanley Medical College, team 4.
Sir, present, sir.
Okay. And team 6, Bangalore Medical College.
Present, sir.
Okay. And team 7, CMC Vellore.
Yes, sir, present.
Okay, Bal Prashant. Prashant, you are there?
Yeah, sir, yeah.
Okay. Team 8, Safdarjung Hospital, New Delhi.
Present, sir.
Okay, Sri Krishna.
Team 9, RML Hospital, present.
Okay, nice. Team 10, BGMC Pune. Team 10, sorry. Team 10, BGMC Pune. Anyone from BGMC Pune? Okay. I move to team 11, Kilpauk Medical College, Chennai. Students from Kilpauk Medical College, Chennai. Next, I move to team 12, MAMC. Students from MAMC, New Delhi.
Present, sir.
Yes, ma'am. Kilpauk online.
Okay, team 11, Kilpauk. Who is that? Can you switch on your video, please?
Switch on your video.
Team 11, Kilpauk Medical College, please. Okay, fine, boss. And team 13, Faridabad, ESIC Faridabad. Students from ESIC Faridabad. Hello.
Yes, ma'am.
I can hear a disturbance. I request other people to kindly mute your mobiles, except for apart from team 13, ESIC Faridabad. Is there anyone from ESIC Faridabad, PG's team 13? Okay, fine. Now team 14 from SRMC Chennai. Team 14. PG's from team 14.
You go ahead, Rohit. You just mark that they are absent at roll call. If they come, they will enter in the chat box.
Okay, ma'am. Next, team 15, AIMS from AIMS Bhubaneswar.
Present, sir, present. Dr.
Team-
Ahana.
Okay, fine.
Okay, ma'am.
Ahana Bandha. Okay, fine. And team 16 from AIMS Rishikesh. Students
Present,
from-
sir.
Okay.
I think,
Ma'am, one final call, ma'am.
yeah,
Team
Ma'am.
10, BJMC Pune. Anyone from BJMC Pune? And team 13, ESIC Medical College Faridabad. And team 14, SRMC Chennai. Okay,
three
ma'am.
teams are absent.
3 teams are absent. So I will
You
proceed
just
further now.
keep mark at present, the absent, and later on at the time of question session, if they are present, we can give. Okay. Today's session, the team 5 from AIMS New Delhi, Dr. Nandini and Janardhan, they will be presenting the session. I welcome and wish you both all the best. And today's session details, the first PGs will be presenting the case for 10 minutes. After that, 40 minutes will be the discussion. Each panelist or in combination can discuss the case from starting to ending. And later on, one spotter for 10 minutes, one instrument for 10 minutes, X-ray for 10 minutes, and OSCE for 10 minutes, counseling and operative session for 10 minutes, and documentation for 10 minutes. So according to the sessions, the marks will be allotted by the judges. After the end of the session, there will be the other teams, other than participating teams, will put questions. For each team, 2 minutes will be allotted, and the presenting team has to answer. After case presentation, the panelist discussion will be there. After completion of the whole session, the panelists will give their analysis about the page's performance and their suggestions for improvement and their opinion about the Plastiquest and any suggestions to improve. I welcome the session team 5 to start their case.
Thank you, ma'am.
One minute, ma'am. I'll stop sharing my screen and
Yeah.
allow them.
Enter this. Right. Good evening, everyone. Ma'am, I just want to confirm if the screen is
Yeah, it's good.
visible.
It's good, Nandini.
Okay.
Today we are going to discuss in following this: patient demographics, chief complaints with history, examination, investigations, and treatment plan. Patient Miss S of 22 years old female from Gopalganj, Bihar, who present to us with history of tightness in the neck and inability to look upwards, and history of inability to move her arms overhead and inability to make fist with bilateral hands, and history of deformed bilateral breast since 5 years. Patient history of presenting illness. Patient have a history of flame burns 5 years ago when she was cooking in her kitchen, which was semi-open type, on a slab in standing position. Due to a gas leak, there was sudden explosion when she lighted the gas and her clothes caught fire. She cried for help and tried to douse the fire using her hands. Meanwhile, her brother rushed to the place of incident immediately and doused the fire using a bucket of water and removed her clothes. She was then covered using a cotton sheet and rushed to nearby government hospital, where she did not receive any treatment and was referred to higher center for further management. But she did not turn up to any hospital and was treated at home by local ointment application and by leaving it open. History of blisters over anterior trunk and bilateral upper limb, which rupture on its wound, and the wounds took 4 to 5 months to heal completely as per the patient history. She did not get any dressings done, nor did she use any splintage or massage the scar, use any pressure garments or physiotherapy at her course. She used pillow underneath her head to sleep and flexes her neck to achieve lip seal while consuming meal. She also gives history of minimal salivary dribbling from bilateral angle of mouth. No history of inhalational injury, difficulty in swallowing or speech, no history of fever, and no history of loss of consciousness or any history of fall or head injury, any other injuries. No history of previous blood transfusions or surgeries. Family and personal history. Family history, she was burnt alone. A personal history, no history of smoking, tobacco chewing, or alcohol intake, no known comorbidities. General examination, she's a young girl, moderately built and nourished, oriented time pleasant person who is conscious and cooperative. No pallor, icterus, cyanosis, clubbing, lymphadenopathy. Her pulse is 85 beats per minute in right radial artery in supine position. And blood pressure is 110 or 60 millimeter of mercury in right arm in supine position, and 97% of saturation at room air. Her systemic examination within normal limits.
Coming to the local examination, patient was examined in sitting and standing position in a well-lighted room with arms by her side in forward-looking gaze. The inspection is described under the following headings, but we are going to concentrate on the neck mainly. So in inspection of the neck proper, there is contiguous mentosternal band as shown in the figure. And the vertical and the horizontal extent is from the bilateral mastoid region to 1 centimeter below the clavicle laterally, and in the midline there is ectropion of the lip, and the band is extending just above the sternal angle, and laterally it is like 6 centimeter medial to the acromion process on the right side and 9 centimeter medial to the acromion process on the left side. There's invagination of the lower lip with gingival show and hypertrophic mucosa having proclined teeth, and the oral commissures are lost. There is excoriation that is present at the angle of mouth on the bilateral side. Non-discharging sinuses are present, and there is obliteration of cervicomental angle. The forward gaze is maintained. The scar is normal in color to the surrounding skin. The mouth opening is 3 fingers and class 2 according to Malampati grading. Anterior and posterior trunk examination, there are multiple islands of hyperpigmented patches as in the figure, and the nipple area complex is unequally placed. One in the right side is 4th intercostal space, left side it is 5th, with 13 centimeter NAC placed 13 centimeter from the sternal notch and 15 centimeter.
Dr. Nandini only described the neck because she has a bilateral axilla. Yeah.
Okay.
Only restrict to the neck and face
Okay.
neck.
Coming to the palpation finding, there is no local rise of temperature. The scar is non-tender, and inspectory findings are confirmed with respect to size and extent of the scar. The scar is supple and pliable. It is pinchable all over in the neck region, and sensation of it is normal. And the overall Vancouver scarring scale was 9. And the angles of the neck, patient is able to flex from 30 to 90 degree. Extension is not possible. The lateral flexion on the right side is 0 to 20, left side is 0 to 30. Lateral rotation is 0 to 20 on right, and left it is 0 to 30. And examination of donor side, it's free of scar. Bilateral shoulder and arm scarring is present. And my diagnosis in this case will be grade 4 post-flame burn with mentosternal neck contracture, with lower lip ectropion, with bilateral ear post-burn deformity, with bilateral grade 3 contracture of the axilla and hand, with bilateral deformed breast.
Dr. Nandini, in the examination, like you said, only unable to see upwards. That is your complaint regarding a concern with the neck. She don't have any problem in the neck pain, side movement of the neck, and drooling, because whole of the upper lip is ectropion, sulcus is blunted, it is visible. So maybe there is a continuous drooling of that is a significant if it is there. I think with the photograph, it appears to be. So there is a difficulty in chewing and deglutition also because the lip is almost ectropion. So I think if it is not there, it is less likely, but only your complaint is just to unable to see upwards as far as neck is concerned.
Ma'am, her chief complaint was that she was unable to look upward, and on history of presenting illness, when we asked her
that is okay. If it is there, then it is a significant, if there is a drooling and if there is like difficulty in moving neck sideways also, this is significant. Maybe she is having because it's a almost flex deformity, pain in the neck also, if it is present. So these are, important common complaints, chief complaints, if they are present. Because with such a severe deformity, I think they must be there.
She did not give history of like very minimal dribbling of saliva is what she told, because she had she says that she is able to take her meals easily. She flexes her neck and she can achieve lip seal also.
Okay, it's all right. But because drooling is not with the meal only, it's a continuous. I mean, it's an intermittent without meal also.
Yes, ma'am. Yes, ma'am.
And in the history, have you taken any history of convulsion, which is important in cases
ma'am, she does not have any history of seizures, ma'am.
Because you have not mentioned, that's why I'm asking. And in the examination, you have not mentioned about the occlusion.
We mentioned, ma'am, with procline teeth.
She has proclined
teeth
with ectropion of the lip.
Okay. And regarding that is okay, and the posterior teeth, they are in occlusion.
Ma'am, on flexion, she is able to, ma'am. Not like normal.
Okay, in the examination, like you mentioned, there is a band, sternomental band. It's not a band, it's, a very broad scar which is extending one side of the neck to the other side. It's a broad contracture which is present and which is pulling the cheek also. In the examination, I think you have to mention there is a pulling of lateral angle of mouth also. Eyes are not clear, maybe there is a scleral show or not, but there is a pulling of cheek skin downwards. This is also a finding on one side. Ear, I cannot say because lateral is not there. So the pulling of lobule of pinna is there or not? I don't know. Maybe
it's not.
Can you show the lateral one?
Yes, ma'am.
No, opposite side. Another one. Left side.
Yes, ma'am. I'm going.
Yeah, there is, and the band, just it is continuous with the, I think, on the left side. Little bit pulling of the lobule and pulling of the angle of mouth. And it's a broad scar with the multiple bands, which is running from the lower face to the sternal area.
Yes.
So you mentioned about the cervicomental angle, isn't it, Nandini?
Yes, ma'am.
The other angle you need to mention, the other angle, another angle between the lip and the chin. What is that angle called?
Yes, ma'am.
The labiomental angle.
Labiomental angle.
Why I am so specific about it? So when you do a reconstruction, it is difficult to reconstruct the labiomental angle, the anatomical, the structure of that angle. It's difficult for you to bring that angle. Even the cervicomental angle, you can bring it. But the labiomental angle, the vermilion border, everything is very difficult to reconstruct. So you must specifically say about that also. And you said the scar is normal. You cannot say the scar is normal. It is a scar. Scar is not normal at all. So, and there are areas of hyperpigmentation and hypopigmentation. So don't say the scar is normal. Okay. And regarding the donor areas, what are the donor areas you have examined?
Bilateral thighs and bilateral legs we examine, ma'am. Bilateral thighs and like entire lower limb is free of burns.
Entire lower limb. Okay.
Yes.
So we'll talk about the options for the donor area when we come to the management at the last. Okay. So from history, can you summarize what are the salient points? We'll start from the history. Can you summarize the salient points that led to this sequelae?
She had a burn, ma'am. She had a burn, and following that, she did not get any treatment.
First,
and
tell
she
me
did
what sort of burn it was?
It's a flame burn.
It's a flame burn, yeah.
It's a flame burn. Following that, she did not visited any hospital, and she did not get any treatment in the form of dressings or surgery, and conservatively managed at home.
And what was the healing time?
With 4 to 5 months, ma'am, for complete
all the
wounds.
All the raw areas to heal, it took almost 5 months. So these are all the salient points. Isn't it? The flame burns, so not undergone any treatment. And why did it take 5 months to heal?
Because of the degree of burns might be superficial, deep to deep dermal burns. So it took 4 to 5 months.
It's not superficial. It is a deep burn that has taken.
Deep burns. Yes, ma'am.
And is healed by secondary intention. So that is the reason it has led to this sequelae. Okay.
And there is no history of any splintage or physiotherapy or massage. So it becomes
or usage of any pressure
the patient has not undergone any treatment, then how does splintage come into the picture?
Yes, ma'am.
Yes, ma'am.
So then tell me now, then, when does splintage starts in the case of a burn involving the extremities and joint surfaces or the neck? When does the splintage start?
When we do some intervention, when she visited some hospital, doctors might have advised about the splintage.
No, I'm just asking, when do you start splinting? Do you start splinting on day 1 or after debridement or after a definitive skin cover? When do you start the splinting?
At the patient visited hospital in acute burns only we start splinting, ma'am.
Yeah, you can start on day 1 itself because when it is across the joint, you can. When you do the dressing, you can always do the splinting in a functional position. Okay. So these are all the points you want to highlight.
Yes.
Okay.
So I have one question to you. You said that during her treatment at home, she was using a pillow to keep her head. So can you tell me why do all these patients like to keep a pillow under their head when they have acute burns?
Position of ease, sir.
Position of comfort.
Comfort.
Comfort for what? What purpose?
It's difficult to keep your head extended. It will also pain.
Keep it flat. Keep it flat. I'm not saying do extension, but they purposely, all of the patients, despite you're telling them, maybe they were never told that don't keep the pillow, but everybody wants to keep a pillow. So how does keeping a pillow help the patient become more comfortable?
It to avoid the stitching. So
that is one. So the pain will be little less.
Pain will be reduced. Yes,
and I think the more important thing is that these patients find that when they are keeping their neck flexed, it is easier for them to get fed. So that is one of the reasons. Keeping neck flat, it's so difficult to have something inside your mouth. So they tend to keep their neck flexed. And, so it is a position of comfort, never, no doubt about it. But the very fact of feeding, getting, little easier by keeping the neck flex leads to they are using the pillow all the time. Okay.
Yes, sir.
Yes, sir.
So other thing you said that at some places the scar is hypopigmented, at some places the scar is hyperpigmented, although I don't find the scar being hyperpigmented at any level. So where will the scar be hypopigmented and where it will be hyperpigmented? And what is the significance of that?
Sir, in case the dermis is involved, in cases of deep burns, the scars will be hypopigmented
Hypopigmented.
because there's lost the dermal elements or appendages is totally lost.
So what kind of scar will be there when you have a deep dermal burn?
It will be an atrophic hypopigmented scar, sir.
In deep burns, in deep dermal burn. So you understand there is a superficial burn, there is a deep dermal burn,
deep
and there is
dermal.
deep burn. So
Yes,
in
sir.
deep burns, you say it will be hypopigmented,
Yes,
like
sir.
this. Okay. So what happens in deep dermal burns?
It can be hyperpigmented, sir. It can become hyperpigmented.
No, something more important. So the deep dermal burns tend to heal with hypertrophy. So you will find
Hypertrophic
that,
scar,
yeah,
yes,
so
sir.
these are hypertrophic scars.
Yes.
They are much more uncomfortable. And if you have a deep scar, which is hypopigmented, you can be very sure that the moment you release that, the secondary raw area which will be created upon release will be much bigger. You can anticipate a larger area in such scars, as opposed to a hypertrophic scar, which is having not that much loss of tissue, but it is because it is unsightly and hypertrophic. So the raw area you create after release of that contracture will be not as enormous as it would be in a deep one. And the deformity will also be accordingly much more if it is a deeper burn.
Yes, sir.
Other thing is, as Dr. Sridevi had also alluded to, what are the various anatomical zones when you are talking of these patients and we concentrate ourselves in the neck area only? So what are the anatomical areas which are being affected here? Could you just tell me? That one is, I can tell you, first example I will give you, her neck is affected, right? Tell me what other areas are affected.
So lower lip is affected.
Lower lip is affected, and else you have actually covered her eyes. I want to see her eyes.
Yes,
We will just take
we
it.
will.
You have any picture in which there is?
Yes, sir.
Yeah, just show us that.
We'll take this off.
Yeah.
Sir. 1 minute.
It appears that scleral show may be present, I think.
Yeah, there could be, external pull on your lower eyelid. So you could find that, you could be seeing the redness of the conjunctiva there. It may not be ectropion, but it is extrinsic ectropion, as you say.
Yes, sir.
So could you just enlarge that area? Maybe she doesn't have it.
Scleral
She
show
did not have it.
It is not there, but it can be possible, right? And then you mentioned something about the angles of the mouth.
Yes, sir.
Yeah, there is little more scleral show, if you can see here in one of the pictures, but probably it is not very significant. So you're telling something about the angle of the mouth. So could you describe this deformity in little more anatomical detail?
Angle of mouth, sir.
You said that both angle of mouths are not seen.
The commissures are lost, sir. Bilateral oral commissure is lost. And there is ectropion of the lower lip with the mucosal show, and there's hypertrophic mucosa. The lower
mandibular teeth are procline.
They are proclined, sir.
Correct. So do you see any part of the vermilion in this patient or not? Or you are seeing only the mucosa?
Only the mucosa.
Mucosa.
Only the mucosa. So it is very, very unlikely that the vermilion will be lost. So if you were to examine this patient's lip inferiorly, you will find that there will be a chunk of the vermilion lying there.
Yes,
I am yet to see a patient in which there is extensive contracture, but the vermilion is also lost. So you must specifically tell us that whether the lip vermilion is available or not. Because after you release the neck contracture and you're trying to create a labiomental angle, as Professor Sridevi had said, so it is imperative that there should be some vermilion also. Only then you will be able to create that angle. So you must mention about that. I'm sure it will be present in her, but you can't see because it is so much everted here.
Yes,
it was invaginated down.
The skin is inside invaginated and the slip is like ectropion.
Correct. Right.
We
So
could insunate our fingers, sir.
you could insulate your fingers
Yes,
there.
yes,
Yeah,
yes.
yeah. So, right. All right. So can you have an idea how much of defect will be created and how much skin graft you will be requiring post release of this neck contracture?
Sir, we marked as apparent defect. This is the markings done on the patient, sir. We can mark the incision at the maximum tension line, and we marked a fishtailing at the neutral line at the end of the scar with the 45 degrees inclination at like the length of the fishtailing is 1/3 of the incision. And we measured a true defect by the arc method, sir, like kind of arc method.
So
with the normal
just stop here, please. I just want to know
Yes, sir.
that why do you want to give this fishtailing here?
So it will prevent the recontracture, and while releasing, if it is in a single line, it will give only an elliptical shape. And if you give fishtailing, it will become a trapezoid. So we'll achieve the maximum relaxation after releasing.
And where do you give this fishtailing?
Sir, up to maximum at the junction of scar and the normal skin. But in this patient, the scar is extended beyond also. So we have given fishtailing at the neutral line, sir.
Okay.
We should not cross the neutral line.
We should not cross the neutral. There is no effective beyond the cross lateral get to posterior.
Correct.
Yes.
That's fine. Yeah.
And we maintain an angle of 45 to 60 degrees.
Fair enough. Okay.
How you measure this, as sir asked, like true and the apparent defect?
Ma'am, we will be marking 3 points, ma'am. One in the midline here, for example, A. Then ends of these two lines,
For
B
example, like what is that point? What is that point?
Midpoint, ma'am.
Where?
Midpoint. And then ends of this,
Line,
like
incision.
here, the incision line, A, B and C, ma'am. And then the fishtail, what we have drawn, we are going to mark each of those points as well. And then we are going to measure the distance from then the fixed bony landmarks like the angle of the mandible, the acromion, and the symphysis mentae, and we can take sternal angle or the sternal notch, one of it. And once all those
the
bony
chin is almost, sternum, it is adhered to the sternum. Is it palpable? Chin was palpable.
Ma'am, on flexion, yes, we could like palpate it, ma'am.
But you have to be in the, as much as extension patient you have to mark in that position, not in the flexion.
Flexion, yes, ma'am.
Measuring the defect.
Yes, ma'am.
Yeah.
So,
So are you going to release only the neck contracture, or are you going to address the ectropion of the lip in the same sitting? If yes, what is the reason that you want to do it in the same sitting? Or if you don't want to do it in the same sitting, what is the point in favor of that?
Sir, once I have given the incision, I will assess if the lip is going back or not. If it goes back, there is no need to release it.
You think it might go back?
Sir, because she is having this ectropion because of the pull, the scar is pulling it here.
What is the extrinsic or the intrinsic contracture?
Yes. So that will take care of only the extrinsic contracture, as there was a comment just now.
Yes.
So if there is an intrinsic contracture, that will also need to be released. So whether you want to release that intrinsic contracture at this time or at a later date, and why?
Sir, would prefer to do it at a later date because I don't want to hamper the vascularity of this region, sir. Already I'm giving an incision here.
So what? How can the vascularity be hampered?
Is vascularity going to be hampered by your incision?
It will not hamper. It will not be hampered, I can assure you.
And one more question. And do you feel that just by making these incisions alone, you are going
to get released
of the neck, or you are going to get a full correction of the labiomental angle? Is this incision alone enough for you to achieve a full neck extension? And at the same time, with this amount of scarring, do you expect a normal labiomental angle just by release of the scar?
No, ma'am.
So this is quite extensive, isn't it?
Yes,
So,
ma'am.
and as Dr. Ramesh asked, is there any necessity to correct the ectropion of the lower lip now or not? Very simple. Yes or no?
There is necessity, ma'am.
Isn't it? It is absolutely indicated because as you said, the patient is able to close the lip only when she bends down, isn't it? So
Yes,
once you release the neck, her lip will always be in a position of ectropion and she'll be having continuous drooling. So that itself, any functional disability is a definitive indication for correction. Okay, the functional disabilities, apart from the neck movements, it is also the drooling of it is also the inability to achieve a lip seal. Okay, so it is absolutely indicated.
Yes, ma'am.
Yes, ma'am.
Yeah. And I agree with your, little fear that it may be difficult for you to manage two raw areas, one in the labiomental area and other in the submandibular and the neck area. But as Professor Sridevi said, if you are able to do it in one stage, the patient's rehabilitation is much faster.
Yes, sir.
And you are tackling the extrinsic and the intrinsic components simultaneously at the same time. And that gives you the best results. But I agree that, if you are not very confident or if you have short of donor site for the graft, then probably you could just do the neck and then at a later date, you could go and do the lip. But in ideal situation, where you have enough donor site available, as is available in this patient is well preserved, and during the surgery, there is no issue. It might be in the fitness of things to tackle both the intrinsic, extrinsic contractures of the lip also, along with the neck contracture.
Okay, sir.
Okay.
Yes, sir.
My next question also, is it possible for you to get a neck extension by this single incision? So what types of release do you plan in the contracture? In a post-burn contracture? Is it only incisional release, and what is the other type of release? Is there any necessity to do an excision of the scar and excisional release? Do you do that or do only an incision? So when there is so much of scarring, and when you showed the other photo with the normal configuration of the neck, so just by this incision, is it enough to achieve the full neck contour? Is it necessary to excise the hypertrophic scar that is present? What do you feel?
So the answer is hidden in the question itself. She gave you a hint that if there is hypertrophic scar, you might need to excise it. So why do you need to excise it in the hypertrophic scar situation?
Dr. Nandini is not in the screen.
Okay, right.
Nandini?
I think they just lost the connection.
Yeah, just lost connection. We'll wait.
Yeah. Yeah, we'll wait.
Yeah, you lost connection, Nandini. Am I audible to you?
Yeah, he is muted, I think.
Yeah, please unmute yourself.
Yeah.
Dr. Nandini, unmute yourself. Lakshmi, madam.
Yes, sir. We are audible.
Yeah, now you are audible. Yes, go ahead.
Yes, sir. Sorry, sir. Yes, sir.
It's okay.
We will
We're
share
talking
the
about,
screen.
we were talking about incisional release and the release by excision of the scar.
So what are the situations in which you need to excise the scar to release to have an effective release?
So when we have enough donor site, we can go for excision release, sir.
Or that is, if you are rich, you should spend money.
If there is
My next
hypertrophic
question will
scar,
be how to increase the availability of the donor areas.
Majority of patient will have a extensive donor area, but you cannot, excise whole of the neck there. There should be other criteria.
Yes.
mainly if
So I said there was a hint in the question itself. She asked you, why do you need to excise in hypertrophic area? Why? So tell us, why should you be excising in hypertrophic scar?
cosmetically it's not very pleasing, sir. So
in any
For
case,
that, ma'am.
patients with neck contracture, cosmetics is probably not that important. What else is the problem with the hypertrophic scar?
There are always two
Lot of
aspects of plastic
itching
surgery,
and
isn't it?
lot of
Cosmetic and functional.
pruritus.
There are two aspects of
Patients
plastic
have lot.
surgery always, cosmetic and functional. Why do you say only cosmetic in hypertrophic scarring? So whenever there is a hypertrophic scarring, the amount of contracture is also more, isn't it?
Yes, ma'am.
It is not necessarily for cosmetic reasons. It is also for the functional reason to bring about the normal movements of the neck. Okay. Fine.
And in hypertrophic scar, if you would recollect that it heals with epithelialization, repeated epithelialization. So whatever you are leaving behind has a tendency to have repeated breakdowns. So it is while agreeing to your contention that it looks unsightly, it has also a tendency to repeatedly break down. So you get rid of that. And secondly, in many of these situations, there might be sinuses running in between those hypertrophic scar bands. So for patient, maintaining hygiene is also an issue there. So in all these areas, you are probably forced to excise that area. Mere incision release will not be enough. I think that's what Professor Sridevi was alluding to.
Yeah. I think he went straight to management before Nandini could finish off her investigation. And the
Yes.
So finish
Right.
off Nandini.
Yeah, we could go back to investigations now.
You could just tell the specific investigations that is necessary for this patient.
Ma'am, specific investigation we would order for a X-ray neck, AP and lateral view, ma'am.
For what?
One
Why
is to look for, ma'am.
What will you see in the cervical spine X-ray? What do you want to see?
We'll see the trachea, whether it is in the midline or any anterior pullo is there. And second thing, we'll see the cervical spine, ma'am. When the long-standing contracture, any...
Yeah, long-standing. Very good. Yeah, long-standing contracture. You want to see the position of the trachea and the position of the
cervical spine.
Okay. And what other investigations?
Ma'am, routine blood investigation for the anesthesia purpose, for the anesthetic fitness.
Okay. And then
yes.
What other specific investigations for the donor area? Your mindset is only reconstructive option, or you have multiple reconstructive options?
Ma'am, in our patient, we have one reconstructive option, that is excision release and grafting, ma'am, because her shoulder, arm region is all scarred.
But you said
So
both the lower limbs are free, isn't it?
Ma'am?
Both lower limbs are free, ma'am.
Both lower limbs are free, isn't it? So both lower limbs are free, both thighs are free, you said. So you meant only specifically for a split thickness skin grafting, or any other option you have from the thighs?
We can do a microvascular free tissue transfer as well, ma'am.
Okay, so what investigation you want to do for that then?
We would like to get the Doppler done, ma'am, for the perforators, to mark the perforators.
Specifically that you wanted you examine the donor areas. So I just asked whether what are the other things you notice in the thigh, and what are the other probable donor areas you wanted to see. You mentioned only about the, isn't it, lower limb, and a microvascular free flap. You were talking only about anterolateral thigh flap. We'll come to disadvantages of the ALT afterwards. But any other flap you have in mind? Any thin flaps you have in mind? You want to go for a Doppler study of that also?
Medial thigh flap.
So I said thin flap, thin pliable flaps.
Thin pliable flap. We can take from back also, scapular.
But she has scarring
over the back, ma'am.
Even upper limbs everywhere, she has scarring.
We can take a thin
region everywhere.
Yes, ma'am.
Okay, so can I just interrupt them? You discussed that you would like to have a soft tissue X-ray neck, and you said that you want to see the position of the trachea and
the cervical spine.
Cervical spine.
So trachea. How can you expect that the tracheal position will be changed? Is it trachea or something else which you are more interested in knowing? In fact, it is not for you, it is for our anesthetist friends. So what is happening there that you're trying to see it in the soft tissue X-ray neck? If you see there, the trachea is in any case, you have taken lateral X-ray here. You have not taken a AP X-ray, right? So the position of this trachea will be central only in this patient. But what happens to a particular part, which is very, very important for your anesthetist? And in fact, if they come to know of that finding, they will have to alter the technique of giving anesthesia to this patient. So what happens in a neck contracture of this magnitude?
The trachea will pull anteriorly.
Not trachea. Before trachea, what is there? When you are intubating, what is there? No. What does the anesthetist first see when they are intubating? They don't see the trachea.
Epiglottis. Once
Epiglottis. They will see epiglottis. All this is distorted. So, in fact, this epiglottis will be covering that. You may not be able to visualize the trachea. And so there is a special, flange in their endotrachea, in their laryngoscope, which is little longer. So it pushes that epiglottis up so that you can visualize the trachea. So that is why you want to get this soft tissue X-ray neck, and it can give you an idea what is the position of the epiglottis like. So you require a soft tissue X-ray neck, not X-ray neck.
Yes.
So X-ray of soft tissue neck, right?
Yes, sir.
So that was very important. I thought you should pay a lot of attention to getting a soft tissue X-ray neck.
And Janardhan, he told that there were non-discharging sinuses.
Yes,
What are these sinuses, Janardhan? How they are formed? He told that during the examination there were non-discharging sinuses.
Yes, sir.
What are these sinuses? What way it is significant?
So sometimes healing, there is a scar between the normal skin and the healed skin. So the normal skin will invaginate and invaginate. So it will become a blind ending sinus. If some hair growth is inside, it will becomes infective repeatedly. So we have to excise that, sir. That is also indication for excision release.
Okay. Then in the complaint, he told the trolling of saliva and aversion of the lip and all those things. Does not patient herself told her about disfigurement?
So she herself, like after we asked, she also, I had drooping of saliva also.
That too, occasionally, she said.
She said.
What about her
But
disfigurement? Just mention about her disfigurement. Does she wanted to improve cosmetically, or she has not told anything about that?
Sir, actually, she stayed inside the home only. So she has not went outside the home till after burn. So actually, some other person only took her to the hospital. Like major function, both disfigurement and the neck contracture, sir. Function and functional impairment and the disfigurement, both are complaints, sir.
How describe about her lower jaw? Describe about her jaw. How does it look? How many tooth are there inside?
So the teeth are proclaimed, sir. The jaw is in
open jaw.
Open by it occlusion will when I try to extend it is open by deformity. The occlusion is not able to not proper. But when
how
she
she had
is
this
able to,
proclined teeth, how it occurred, proclined teeth?
So because of the pull of the contracture, sir. Long-standing contracture.
And then also you mentioned about you also told that mouth opening is 2-finger birth. So she does not have any difficulty in swallowing food and other things. And you also mentioned about the Mallampati classification of mouth opening. What is that Mallampati classification?
So Mallampati classification, there are 4 grades of classification. For the class 0, we have to build the both pillars, soft palate, uvula, and hard palate. Class 2 is on see the part of base of the uvula and soft palate and hard palate. Class 3 is only soft palate and hard palate. Class 4 is only hard palate. It is for the purpose of intubation, sir, like anesthesia.
So you are able to do that now? You can able to open the mouth and see all those things and arrive. She can. She is able to do it.
Yes.
Then what is the name of this classification for neck contractures we normally use? Whose
Sir,
name the classification?
Archer classification, sir.
Archer's classification. Under Archer's classification, it is.
Sir, under Archer's classification, it is extensive. It is extensive, sir. Archer classification into mild, moderate, severe, and extensive. It is comes under extensive classification.
Okay.
Dr. Janardhan, what is the diagnosis? You have not told about the diagnosis.
Post-burn, it's a grade 4 post-flame burn with mentosternal contracture of neck with the lower lip ectropion with bilateral post-burn ear post-burn deformity with bilateral grade 3 contracture of axilla and bilateral grade 3
Not
contracture
over,
of hand.
only limited to the face and neck only.
Grade 4 mentosternal contracture with lower lip ectropion with the bilateral ear post-burn deformity.
Okay. Just a little bit refined it. Just modify a little bit.
Lower lip ectropion with malocclusion.
Malocclusion.
No. Complete diagnosis.
You want to talk about malocclusion in a case of soft tissue contracture? I don't think, Madam Dr. Durga and Dr. Ramesh, you have to tell.
Yeah, sure.
Because I'm not in favor of talking about occlusion in a case of soft tissue.
No. Diagnosis should be very specific, you know.
Yeah, because occlusion we talk about in bony injury.
Repeat your diagnosis.
Grade 4 post flame burn contracture with severe mentosternal contracture of neck with lower lip ectropion.
It will be better if you will say post-thermal burn contracture of neck and lower face with ectropion lower lip with hypertrophic scarring. You know, that includes everything, you know, because lower face is also pulled out, yeah. And little bit because whole of this is scarred, so little bit about the scarring. You should not include all the points, but the main points should be included in the diagnosis. Now proceed with the investigation. You finished with your investigations?
Investigations over.
Yes.
Next, what is the next slide, Nandini?
Ma'am, apparent and true
Yeah.
difference.
So what is your
Doctor.
treatment? What is your treatment options now?
We'll go for incisional release.
What is your aim of treatment? And what anesthesia are you going to give? And of course, definitely in postponed contracture, you have to tell a few words about the role of the anesthetist also.
Yes. Our goal of treatment.
Yeah, goals.
Yeah, our goal of the treatment is to to give her the normal forward gust and to give the neck range of movements completely and to give a soft and supple cover over the neck.
And lip seal.
And lip seal and adequate
alimentation.
Adequate lip seal alimentation. And we'll counsel her and we'll take decision with the anesthesia team. And we'll tell her like she needs, she has a candidate of difficult intubation and she needs a fiber optic awake intubation. So accordingly, we will counsel her. So
preoperative counseling of a prolonged splint plate and keeping her neck in extended position, all those things we will counsel her preoperatively on them.
And one more counseling. If the anesthetist is not able to do a fiber optic intubation, what else will you counsel the patient for?
We'll release under local anesthesia. And we will release after that. It will be easy for anesthesia to get a oral intubation.
So you said you want to bring the full function of the neck. You said about the cosmetic aspects also, isn't it? So the cosmetic aspects of the neck, what are all the things you want to bring up? What are all the things that are obliterated now? What are the things that are lost now? And what are the things you want to bring in now, as far as the neck is concerned?
Ma'am, she has lost definition of her mandible jawline and also the thyroid cartilage and the sternocleidomastoid.
You're talking about the lower border of the mandible, and then the center, you
Yes,
have to
ma'am.
tell about the chin, and then when you go from
Chin,
above, below, on the
Savoya
side.
depression.
You have to maintain the
sternocleidomastoid prominence.
sternomental angle and labiomental and the sternomental angle.
Cervicomental.
That is
Yes, ma'am.
important. Yeah, cervicomental angle. That is important to have.
And the labiomental angle.
Yeah, that is the goal
And-
we want to achieve, to have a proper,
And then in the side, superiorly, you said about the lower border of the mandible. On the sides, what landmark is important for in the neck?
Protrusion, the
sternocleidomastoid prominence.
prominence.
Yeah,
And then the
in
subhyoid depression.
Yeah,
Subhyoid depression. Then the thyroid cartilage prominence. The suprasternal notch.
And the clavicle on both sides.
Clavicle on both sides.
Both sides. Okay, fine. So how are you going to proceed now? So the patient is anesthetized. What is your plan now?
We will keep a shoulder bag underneath her shoulder and also multiple rings beneath her head, ma'am. The position is given. And
Yeah,
then
patient is
after painting and
anesthetized.
draping, we will give at the maximum line of tension, whatever preoperatively we have marked, we will give a linear incision and then fish tailing in the ends.
So
Also,
much of
if we
scarring
feel
and all our patients with always hemoglobin levels low, do you want to do something before that?
We'll inject adrenaline solution, ma'am, 1 in 2 lakhs.
What do you call that solution? Is it plain? Do you call it as adrenaline?
Tumescent.
Tumescent,
So
okay.
Tumescent solution.
Yeah, so much of scarring, how much of tumescent will you infiltrate? And what is the maximum dose of lignocaine you can use?
Ma'am, with adrenal maximum 7 mg per kg is the maximum dose we will use.
So what are the components of the tumescent solution?
500. We'll get a tumescent solution with 500 ml of oral with 30 ml of lignocaine with 2 ml of adrenaline in that.
And
That's
12.5 bicarbonate.
Sodium bicarbonate.
Sodium bicarbonate 12.
And then what else?
Like optional, ma'am.
Hyaluronics, but we didn't.
And then
we don't use.
You don't use.
Tranix.
Okay.
Yes.
Fine. So do you infiltrate tumescent solution or not?
No, ma'am.
No, you don't.
Because sometimes post-operatively, like there are two school of thoughts, ma'am. If you are using adrenaline, there can be some bleeders which you might miss because of transient the vasoconstriction that has happened. So with cautery,
so vasoconstriction, the effect of adrenaline, how long is it going to last? And how long is the duration of, and what is your expected duration of your surgery? And do you feel that just because you have infiltrated adrenaline, the effect of adrenaline is going to be there for more than 2 hours and you'll not be able to catch the bleeders?
Ma'am, usually in our institute, we won't.
You don't use
we won't put a yes, ma'am, tumescent
protocol you follow. Okay, my
yes.
point, that's all. The amount of
Yes,
adrenaline you are going to use and the time duration of the surgery for this particular patient is definitely going to be more than 2 hours. Okay, and by that time, that the effect of adrenaline would have been over, isn't it? So I usually prefer tumescent infiltration with adrenaline. Okay, that will minimize the
Ideally, because there is so much of the scarring over here and you will release, ideally we all are using the adrenaline infiltration. That is good because otherwise there will be a lot of bleeding. Ideally, you should use, there is no two school of thoughts because at the end, because it will take almost 3.5 hours. So reactive bleeding is not the issue.
And especially in this patient, when you are not able to use a fiber optic and you are going to release it under local anesthesia, tumescent infiltration with adrenaline is definitely indicated. Supposing it is not fiber optic and you are supposed to do a release under local anesthesia, then definitely you need to use adrenaline.
Yes, ma'am.
Yes, ma'am.
Okay, fine.
Then you should incision and release. How depth you will make the incision?
Sir, till the amount of scar, like we'll get a gritty feeling, sir, by releasing. Till the amount of getting a normal fat or normal tissues, we have to release.
You will go beyond the platysma or superficial to the platysma?
Beyond the platysma. Platysma we
You
have to
find
cut,
in
ma'am.
these cases platysma will be there.
Mostly it will be a scarred, ma'am.
Yeah. So just then proceed with your steps. Then how you will do the release?
We'll give incision at the maximum tension of the scar, and we'll start releasing. And we are start releasing. We are till the amount of getting the normal tissue or normal fat. We are to release, and at the end of the release, and we'll give a fistale at the marked site. So after that, we slowly we'll remove the one of the
How
rings.
you will decide? How you will decide that there is a limit? You know, you have released all the bands. How you will decide, or how you will say that all these contractures have released? What you will see?
We'll start removing one of the rings below, which is placed below the head. Then we'll see for the extension
and
lateral movements. So if still we have a extension lag, then we'll some of the bands at the lateral side or over the anterior aspect, we'll still
And you
release.
have to feel the bands also and see the movements of the neck. You have to feel the bands. Yeah, you can palpate and see with the finger or the forceps. Okay, then after that.
After achieving after removing two rings, and we'll if we achieve a full extension, then we will if still we have some of the soft tissue contractures over the suture line, then we'll give a mild dotting over the suture line. It will further increase the surface area.
In this case,
over the released lines, ma'am, over the upper and the lower lines that we have released.
In this case, what do you think what structure you will come and you are expecting that after the full release in this patient?
Strap muscles will be exposed.
You can leave a little small tissue over the strap muscle if it is completely released. Then after that? After that?
In case if darting is required, then that is given, ma'am. And then once we have ensured that the release is complete, then we will achieve hemostasis, and then intermediate thickness graft will be harvested, and it will be pike rested, and it will be placed in a horizontal direction, like it comes along the RSTL lines, one in the submental region, and then over the neck, so that the cervicomental angle differentiation can be achieved, and quilting sutures will be done of the graft to the bed, and in the periphery we will give a overlap to the normal skin, and we will suture the graft also to the periphery. And syringing can be done in order to, if any, there is
where
any
you will apply quilting sutures? Where you will apply a quilting sutures?
At the base, ma'am, to avoid the dead space.
Where?
The graft to the bed, ma'am. The graft.
That is usually not required. What type of dressing you will apply?
Bolster.
A bolster or a tie-over dressing is
5 minutes left for discussion.
Okay. If you are putting a bolster dressing, there is no need of putting a tie over, quilting the graft. And the thing is that you have not mentioned how much graft you will take, and let's see.
Yes, ma'am. Once we have true defect, we will calculate the same build of the patient and same size. Once we have marked by using these
what
points,
will be their position, neck position of the
neck in extension.
Neck in extension.
Full extension. He should
full
have
extension.
Full extension.
Yes, ma'am.
Then after that, what will be your post-op protocol? Then after dressing, bolster dressing, what you will apply?
We'll put
POP.
We'll put a dynaplaster, and we'll put a POP
over
it.
What type of POP?
4-inch plaster of Paris. We'll customize according to the neck size, and we'll tie over at the posterior neck.
Were you specific about intermediate thickness graft?
Yes, ma'am.
Why not a thin split thickness skin graft, or why not an FTA full thickness skin graft?
Ma'am, thin, it's the chances of contracture is more, ma'am. And the full thickness graft, like for donor site morbidity will be more, ma'am. See, healing will be very less if we take a full thickness graft over this much of raw areas.
Full thickness skin graft is concerned, you are bothered about the donor site morbidity or about the survival of the FTSG?
Survival,
also the
survival.
FTSG, both.
Okay. Supposing the patient has already been operated, and this is the result of the skin graft that was not splintered post-operatively. The patient has gone for a contracture again. What are the options there?
Again, we will re-release and we will do a grafting, ma'am. Like we'll assessment depends how much contracture she has. So depend on that, we will release and we will put grafting again. Or if it is a contracture due to a single band, we will assess by local Z plasties or contracture band release.
The patient already had this amount of contracture that is extending from one angle of mandible to another angle of the mandible. And even after skin grafting, and the patient comes to you 1 year later with the same result, will you go for a skin grafting again? So what is your protocol?
Ma'am, if the patient has a poor complaints, like again the chance of after doing surgery also again chance of recontracture. So in that cases we can go for a flap cover. With a patient has a poor complaints with the physiotherapy and with a splintage, then flap cover might be an option, ma'am, for that kind of patients.
Supposing supposing in another scenario, the contracture is on only one side of the neck. What are the flap options that are available for you?
In this patient, actually both
another scenario where, because this patient has got a contracture on both scarring on both sides of the neck. Another scenario where the patient has got a scarring and a contracture band only on one side of the neck and one side of the chest. What are the flap options that are available?
Ma'am, we can use a cervicoacromion flap, the supraclavicular flap that we epaulette flap.
Supraclavicular artery flap.
Yes, ma'am.
So can you tell me the vascular basis of the supraclavicular artery flap?
From the transverse cervical artery, there will be a branch from the transverse cervical artery, ma'am, supraclavicular artery that will be coming from it, and that will be supplying this flap. Like if we, the width of the flap can.
What is the anatomy? You can identify a vessel.
I request the panelists, as it is competitive session, we have to stop the discussion at this time, and the discussion can continue in panelist time. So,
fine.
We go ahead with your permission. We will
go to the next session.
Other
continue questioning in the panelist session. Don't worry.
Yes. We can. You can continue, but it is just because it is competitive. We are limiting the time.
Because Nandini is my student from pre-MCH, so I'll definitely question Nandini more. Nandini.
Yes,
yeah.
It's a nice discussion. So we'll ask other teams to put questions to presenting team.
Yeah.
So that also we can cover a few more points. Team 1.
Ma'am, good evening, ma'am.
Yeah.
My question is, what is the anesthetic drug commonly avoided in burns patient? For how long and why?
Like we'll avoid succinyl choline. Because
potassium levels, that's mainly in acute burns or something, because the potassium levels can be deranged, and succinyl choline usually affects it increases the potassium levels. So
1 year we will avoid minimum.
But now that theory is like, it's for 180 days or something, it's no longer, we have better anesthetic drugs, so usually not used.
Yes, okay, ma'am.
Yes. Team 2.
Good evening, Team Jitmar. Can you tell me the steps of skin graft uptake, and when you will do the first dressing and when you will do the second dressing this patient? after skin?
Stages of skin graft uptake are stage of plasmatic imbibition, stage of inosculation, stage of revascularization, then cellular hyperplasia and maturation. So in plasmatic imbibition, the graft receives its blood supply, the graft receives its nutrients from diffusion, the oxygen, nutrients, and the fibrin plugs will be formed between the bed and the graft. And in the stage of inosculation, these fibrins around this, the epithelium will start developing. And in the stage of revascularization, and in this stage, there will be there will be only one-sided supply, that is the afferent supply, no efferent supply. And in the stage of revascularization, the connection will be established between these two flaps, and there will be both efferent and afferent blood supply. Thus, the graft will also appear pinkish in color by this time. And then we have cellular hyperplasia, that is the epidermis will proliferate for maybe 2 to 3 weeks. And then in remodeling stage, primary and secondary contractures and all those things.
So state imbibition will be first 48 hours and 40 to 72 hours will be the inosculation. After 72 hours up to 5 days, it will be the revascularization, and maturation takes up to 1 year. So we will do first dressing on post-operative 7 and the second dressing 7, and for second dressing will be on post-operative 9, and we will assess the graft and we will discharge the patient accordingly.
Okay, ma'am. Now team 3, KGMC Lucknow.
Good evening. My question is, what is Mutter flap?
The epaulette flap, that is the cervicoacromion flap, is known as the Mutter flap.
What is the arterial basis of the flap?
It's a branch, the transverse cervical artery, that the supraclavicular branch that comes from it.
I think it is posterior auricular and occipital artery.
For the Mutter flap.
Yeah.
It's almost same as it's the supraclavicular flap itself.
Yeah, but
maybe you are mentioning like there is supply from the acromion, like the pectoral region also. Posteriorly, there is overlapping supply in the occipital.
It can have also from
and
posterior
posterior circumflex humeral also. There can be overlapping supply, yes. But the main axial supply, that is what we are telling you.
Team 4.
Sir, my question to you is, can you enumerate the components of the Vancouver scar scale?
It is pigmentation, pliability, and height of the scar, and pain and pruritus.
Okay.
We have again gradings and subclassification. Right? Pigmentation 0 is normal, then
hyperpigmentation, mixed and
hyper,
hypopigmentation
1, 2, 3. Then pliability 0, 1, 2, 3, 4, 5 normal. Then you have yielding.
Pliability, which have normal, supple, yielding and band and contracture.
Contracture, 5 is contracture.
Height will be 0, less than 2 mm, 2 to 5 mm,
more than
5
5
mm. And pain, pruritus 0, and mild pain or pruritus, and
occasional pain or like severe pain requiring analgesic. And then pruritus is like no pruritus, then occasional pruritus, and or the one requiring medication.
And vascularity, blanching, and red and purple. Sorry.
No, normal, pink, purple, and red. Red and purple, sorry.
Okay.
Next, team 6, Bangalore Medical College.
Good evening, everyone. My question is, what should be the ideal pressure provided by the pressure garments for scar remodeling?
10 to 40.
20 to 25 millimeter of mercury.
Yes. Above what millimeters of mercury it will not be tolerated?
Above 40.
Yes. Thank you.
Okay, next team 7, CMC Vellore.
What is the post-operative splinting? What are the things available for post-operative splinting?
So initially we will do a hard collar by the thermoplastic splintage, customized
Just
according
the
to the
type,
patient.
just the types. No, just the types, please. What are the methods?
Hard collar, soft collar, hard with soft lining.
Any other have you heard winner in the ring kind of?
Huh? What? No?
Winner in the ring, what to see color. Do you know about what to see
What to
color?
see? Yeah, what to see splint. That is like we can make what to see splint by arranging multiple tubes. What to see splint, but we have a thermoplastic splint. Mostly we'll use thermoplastic. If it is a thermoplastic splint is not available, we can create by arranging multiple tubes by like what to see.
What to see is named after how it got that name. What to see?
So what you see is mostly used in the cardiothoracic vascular surgery, which has that tubes. They will use the tubes
No, what is it named after? I mean, what to see is what is it named after?
what to see is the name of the surgeon. No, I think the tube.
No, it's named after the community in Africa where they put a rings around the neck to lengthen the neck.
Yes.
Like how ring they have, how much ring they have. They just categorize the beautiness of their African based on the number of rings they have. That is what is saying.
Okay, team. Thank you, Prashant. Now moving to team 8.
Good evening, everyone.
From Saptajan, please.
Good evening, everyone. I wanted to ask, why can't we use FTG in resurfacing of a post-burn neck contracture wound?
The metabolic requirement graph will be too much, and this is such an extensive area. So FTSG take will not be good. So
but like SSG, even FTG takes its blood supply from the bed. So why are we expecting
FTG takes
also from
FTG
the
takes
edge?
blood supply from the surroundings.
No, the peripheral blood supply is only up to 5 mm from the edge of the FTG, but the rest of the blood supply will come from the bed only. So the blood supply from the edge will be only. Okay. Yes.
The metabolic requirement is very high of FTSG that cannot be sustained with what it might get from the bed.
But why are we expecting that the
done.
bed is not healthy? I mean, because when we release, we are going till the till the point where we find the healthy tissue. I mean, we are going till we see the healthy fat or even till the healthy muscle. So why aren't we putting FTG? And even if we are putting FTG, what other how do we go about it?
We put expansion, we can put FTG. Like still we want to put FTG, we can expand and we can do FTG. That time like FTG loss will be less. That might be an option, but we are not tried.
So we can always use expanded FTGs, or we can take FTG, which is an uncommon method, but we can take FTG and then resurface that area with a thin SSG from the other thigh. But because in such patients there's already positive donor site areas, we don't go about with such methods. But FTG can always be done. Like we do in small finger contracture release. We release it and the bed is healthy and we put FTG. We put FTG. I hope people are doing the same. So it is also more about the donor side positivity. And if we are finding healthy bed, we can always go ahead with putting FTG, because even FTG takes its blood supply from the bed, as long as we reach a healthy bed. Thank you.
Okay, thank you. Expanded FTG can be put, yes.
Next, team 9, RML Hospital in New Delhi.
Yeah, good afternoon. My question for the presenting team is, could you tell me the difference between linear scar contracture and planar scar contracture?
Linear scar
contracture and planar.
Yeah, difference between linear and how does it differ from planar? And so hence the management will also kind of differ.
So in a linear contour, there is a single band will be there. So if the surrounding the surroundings skin is normal, we can do a simple Z plasties. If a planar contracture, the surrounding skin will not be normal, so we have to go for incision release or excision release and grafting.
Okay. Yeah, you're partly right. So linear, the direction of contracture is in one direction, basically. In planar, it is multi-directional. So hence the release, yeah. So multiple directions. So in linear, the release has to be perpendicular to the contracture. In planar, it has to be, it's like the PBC neck that we do. It is a cross cut. Or if it is like, let's say, already grafted and there is graft loss, as in contracture release has been done, it has been grafted, there's partial or total loss of graft. Again, whatever healing that happens by secondary intention will again be planar. So there we'll have to do excision of the scar and we'll have to probably resurface with the flap or something. Thank you.
Now, 10 BGMC Pune. PGs from BGMC Pune. Are you available now? Think. Team 10 BGMC Pune once again. Okay, fine. Now I'll move to team 11, Kilpauk Medical College. Students.
Good evening. I'm from Kilpauk Medical College. My question is, do you know of the classification of cervical burn contractures by Raman Snyder and Donnellan? Can you please elaborate about it?
Raman Snyder and Donnellan. No.
No idea. Sorry.
It's only for a cervical burn contracture. So in severe neck contracture, it is A and B, labiosternal and mentosternal. Moderate neck contractures, we have cervicosternal. We will have multiple bands. See only the upper neck. Mild neck contractures, we have A, discrete linear bands, and in B, we have isolated cervical bands. Thank you.
Okay. Now moving to team 12, MAMC New Delhi. PGs from MAMC New Delhi.
Good evening. PGs from MAMC. Can you tell the difference between the intrinsic contracture and extrinsic contracture?
So intrinsic contracture, when the contracture develops at the site of injury. Extrinsic contracture, the contracture develops due to the shortage of tissue, the contracture of the normal area. So you have extrinsic contracture. The pull of the normal area towards the
injured
site is called extrinsic contracture.
Contracture pulls the normal surrounding tissue and distorts it. So that is.
Yeah, okay.
Okay, now we are moving to team 13, ESIC Faridabad. PGs from ESIC Faridabad. Once again, team 13, ESIC Faridabad. PGs from ESIC Faridabad. Okay, fine. Now we move to team 14 from PGs from SRMC Chennai. Do we have any PGs from SRMC Chennai representing SRMC Chennai? Okay, fine. Now we move to team 15. PGs from AIIMS Bhubaneswar.
Good afternoon. My question is, what is your idea about immature scar and mature scar, and what are their implications in managing post-burn contractures?
So immature scar, it blanches on pressure. It will be pinkish in color, and it has tendency for repeated breakdown also. A mature scar will usually be supple, pliable, almost like normal in like to the surrounding area. The color will settle with time. And coming on to the management aspect, cases like perioral or eyelid contractures, in such cases, even if it's an acute scar, we will intervene in order to avoid the corneal injury and its sequelae. Otherwise, in rest of the areas, we usually wait till the scar matures and then we will be intervening.
So basically, the defining feature is erythema.
So with the resolution of erythema in a normal wound, the immature scar usually progresses to form a mature scar. In burn cases, these immature scars usually undergo hypertrophy. This is because of the disordered collagen deposition. And that is what the implication I was asking about. Like most of them, they cannot progress on to become mature scars. Thank you.
Yeah. Thank you.
We are moving to last team, like team from AIMS Rishikesh. Pages from AIMS.
Hello. Good evening, everyone. So my question is, how will you proceed in case of difficult intubation, even anesthetist failed with flexible intubation, flexible bronchoscopy? So how will you proceed in this?
One is that we will infiltrate the tumescent solution, and then we will do a release so that that will assist them to intubate the patient. If not, then we can even do nasal intubation, wide awake nasal intubation.
Blind nasal
Blind nasal.
and we can do in TIVA with under ketamine
sedation.
Yes, and last one, this tracheostomy. Okay, fine.
Okay, thank you. Ma'am, can you proceed to the next sessions, ma'am?
Any questions in chat box and any audience questions?
Actually, chat box, there is a discussion, ma'am, rather than questions.
Okay.
I don't think we have anything significant. Okay, ma'am.
Then
we'll
we'll
move to the-
proceed to the next session, that is the spotter.
So you have 10 minutes for each session. So please stick to time.
Spotter, you project.
Yes, ma'am. I think it's visible.
No. You have to, like Nandini, you have to withdraw your presentation.
Okay, ma'am. Yeah. We'll stop sharing.
Yeah, stop sharing. This is your spotter.
Yes, ma'am. Ma'am, this is this is a case of left-sided microtia, ma'am, lobule type according to Nagata's classification with hemifacial microsomia, and mostly has
proceed with the discussion. Yeah, you can tell whatever you want to do and all.
Ma'am, in this cases, we first usually 70 to 80% of cases, the microtia is usually unilateral, and 10 to 20% it is bilateral, and they are associated. They have a genetic
confined to this case. Unilateral.
So,
there is syndromic association in this. That is, the patient is having a low set hairline, and there is hemifacial microsomia. No sideburn also. The sideburn is not there in this case. And
so we will see for, we'll assess what is the age, and we'll see for chest circumference also, ma'am. So accordingly, we will decide, like usually we in our institute, we follow the.
We will first get an ENT evaluation done. We can see that in the picture, the patient does not have external auditory canal. So we will get an HRCT temporal bone, and also we will get an MRI to look for the facial nerve course in this. And patients can even have cholesteatoma. So that should be addressed. And there is we should get an hearing evaluation, audiometry done in such cases. Once all of these workup is done, and if the ENT surgeon wants to intervene in case of cholesteatoma or there is any infection or for such cases, we can help them in incision planning. And once all those things are taken care of, then once the child has achieved a chest circumference of 60 centimeter according to the Nagatas. And in cases of, if we are planning for a Brent Brent reconstruction of the ear, then 5 to 6 years of age, we can plan for the ear reconstruction. And in that case, in Brent's ear reconstruction, we will be using the contralateral side of the synchondrosis 6, 7, 8. And we will be making the base plate using the 5, 6. And then the helix is made from the rim of the, 6, 7. And then the rim is made from the 8. And these will be sutured using the nylon. And we will be doing pre-op markings from the lateral. Template is taken from the opposite side. It's marked on an X-ray, plain X-ray sheet that is cut. And then we are going to, preoperatively, we are going to mark the lateral end of the eyebrow. And then from the columella, 2 horizontal lines are drawn. And the axis will be almost the dorsum of the nose angle. So according to that, the axis of the ear is marked. It's usually like 15 to 20 degree tilt will be there to the vertical. And we will be giving a preauricular incision, and we will create a subdermal pocket. And we will ensure that adequate hemostasis is achieved and 1 centimeter extra margin beyond the desired, like whatever the framework that we have created, 1 centimeter beyond that, we will be dissecting it. And once we have carved everything, we have assembled all the framework, we will be putting that into this, the created subdermal pocket, and we will be keeping 2 the Romovac drains. One is around it and one is like on top of the framework. And we will do the closure, and we will be doing a contour dressing over it. And Brent has 4 stages. So the first stage is the framework creation. Ma'am?
I request Dr. Ramesh Sharma sir to ask some questions to the.
So I think Nandini has explained regarding reconstruction of the ear in this case quite comprehensively. An important thing which you have to keep in mind is that these patients of hemifacial microsomia, you also need to evaluate their TM joint status. The mandibular condyle could be hypoplastic. And
ask questions, sir. First you ask.
No, I don't think they will be knowing it. So I thought I will just explain it to them.
Because they are reading extensively.
Yeah.
You ask
So,
that again, you contribute, sir.
Yeah. So, all right. So we need to get their, evaluation of the TM joint status, the height of the mandibular condyle, the ramus, before we start discussing about the ear reconstruction. Because if you start to reconstruct the ear without taking that thing into account, then subsequently when you do something to the condylar head, there might be disparity in the ear placement. So that is important. I think rest of the things what she told was good. And in a case of hemifacial microsomia, you should also be commenting upon the occlusion of the teeth, because on one side the height is less, so there could be cross, bites also in these patients. So you must check all that. It is not a case of only microtia. It is a syndromic microtia, so you have to take into account other things also.
So what are the other things that you have specifically you should consider before deciding on treatment for this patient?
Right.
You will decide on treatment of microtia first, or any other factors you want to correct before that?
Ma'am, that we will get an HRCT temporal bone, ma'am. We will look for if there is any atretic ear canal or something. We will also look for the facial nerve course by getting an.
You said about craniofacial microsoma, hemifacial atrophy, all those you said, isn't it? So when it is involving 1/2 of the face, so what are the other things in that half of the face you want to correct? What are all the things that can be corrected in this cycle?
Once it is stable, once the disease is stable, then we can do fat grafting, ma'am, in these cases.
So fat graft. So you want
Because
to
there is
do fat grafting, or that means you mean to say in this case the deficiency is only of the soft tissue?
Bony and soft tissue both, ma'am. The mandible, there will be hypoplastic mandible also. And
So how will you correct it? Is it hypoplastic mandible? So okay, how will you correct that?
Distraction.
Once the child is around some 8 to 10 years, then we can go for distraction osteogenesis for the mandible, ma'am.
So
if
you
that
plan
really malformation is there.
So my question is, which should be done first? Either a distraction of the mandible or a reconstruction of the ear. Which should be the first?
Distraction of the
mandible will be done first.
So what are the pros and cons of both the procedures? You can, if you do ear first, what is the advantage? If you do mandible first, what is the advantage?
Ma'am, after mandible, we'll see the facial symmetry, and accordingly we can reconstruct the ear.
See, if you see this photograph, what is the placement of the remnant there?
It's low.
It's low, isn't it?
Low. Yes, ma'am.
So once you do a distraction, what can you achieve?
So the scar, the rear.
It is low, isn't it? What are the reasons to say it is low set here? And what are the other things that you will consider before making the pocket? The hairline.
Yes, ma'am.
Hairline
is low set, and the ear lobule is also
and
low
the
set
height
compared to the opposite side.
All these things you have to take into consideration. So it is always a controversy whether you have to do distraction first or the reconstruction of the auricle first. It is always a controversy. But in cases of severe hemifacial atrophy, you can always go for a distraction and then go for a ear reconstruction. What is the advantage of that?
Angle of mandible height will mandible height will be corrected first, ma'am, so that the ear, the future reconstructed ear will not like if you construct the ear first, after mandible reconstruct, the ear will be low. So now the ear position will be corrected.
Corrected. Right. And another major advantage in our Indian population is when you said the microtia reconstruction, you start at 6 years of age. So you delay it more.
Yes,
what happens
in India?
In our Indian population, especially. The amount of cartilage you get, the amount of development of the cartilage and the amount of cartilage you get for reconstruction is more when you plan a reconstruction at 8 or 10 years of age. Because at 5 or 6 years of age, in our Indian children, they are malnourished. The cartilage growth is not adequate. So you can plan even later, after 7 or 8 years also, it can be planned. And another pitfall in this patient, apart from the mandible height and the low set ear, and what other important parameter you will take into consideration?
Soft tissue.
Facial now.
The hairline.
Soft tissue.
Yeah, soft.
Hairline.
Soft tissue deficiency.
So all those soft tissue corrections, when will you do? We have talked about bony correction by distraction of the mandible. Soft tissue, you said fat injection. And I'm asking about the hairline. How is the hairline in this child? If you make a pocket,
it's low set.
Isn't it? So how will you manage that hairline?
Before ear reconstruction, we will mark exactly where the future ear will come, and we will do a hair removal laser, ma'am. So that laser hair reduction, then we'll plan for the reconstruction of the ear. So in the future reconstructed, there will not be any hair growth.
Ma'am, sorry to interrupt. Time is
over. Fine. Okay, you can read on the difficulties in second stage reconstruction afterwards. Okay, and a single stage reconstruction for the ear.
Okay,
ma'am.
Thank you, ma'am.
Next session, Rohit.
This shows X-ray of left hand AP view and AP view and oblique view, which shows distal radial ulnar joint, carpal bones, metacarpal, and all the phalanges. And in the first picture, we'll appreciate there is a fracture over the first metacarpal base, second metacarpal shaft, first metacarpal base with the dislocation, second metacarpal shaft, and the third metacarpal base. And in the oblique view, there is a evidence of first metacarpal base fracture with dislocation with dorsal subluxation. Dorsal, yes, dorsal, and second metacarpal oblique fracture of the shaft with dislocation, and third metacarpal looks like undisplaced fracture, ma'am.
The Gilliland's line.
Yes, ma'am. And all the phalanges looks normal. Carpal bones and radial ulnar joint looks normal, ma'am. And there is a fracture over the fourth metacarpal base also. So fracture in first metacarpal, second metacarpal, third and fourth.
With the CMC, first CMC.
With the dislocation, with first carpometacarpal dislocation. And by no soft tissue injuries, not able to appreciate.
How you will
Yes.
proceed with the case? Like what
Ma'am,
deformity
in
you are
this,
expecting in this patient?
ma'am, there is a fracture in the first carpal with the dislocation in the first carpometacarpal joint. So there is adduction deformity in the thumb, ma'am.
And other metacarpals?
There is a swelling and loss of the arch might be there.
And crepitus.
Crepitus, pain, swelling.
How you will proceed with this patient?
We'll go for we have to first assess for assess the limb clinically, ma'am, whether it is a open fracture or it is a closed fracture. If it is a open fracture, and we'll see the vascular status, like if it is severely like crush injury or something, just we'll put a debridement, splintage, and we will wait. And if it is a closed fracture, and we'll go for open
if it
reduction
is
and
open, if it is open fracture, then you will wait for how long?
ma'am,
If it is clean open fracture, yeah.
Yeah, it is an open fracture. We'll assess what all the structures are lost, ma'am. Like it is a severe crush component, severe crush,
And
and
in
if
this
the vascular,
patient only, what are you expecting?
ma'am,
Severe
it looks
crush
like
of what? Crush of bone or what crush? If it is
soft.
Acha, okay. If the soft tissue is okay and the open fracture is there, then
Ma'am, we'll assess, ma'am. We'll give a good wash and we will reduction at the same sitting, ma'am. Reduction and fixation at the same
what
sitting.
this first
If the wound is
metacarpal
clean,
fracture is known as, this one, what it is called as?
ma'am, it looks like Benedict extra-articular base of it looks like Benedict's fracture. Bennett's, sorry.
Bennett's fracture.
Yes, ma'am.
Okay. Then how you will proceed with the fixation or with the in the open fracture?
In open fracture, we'll debride all the contaminated tissues, and we'll go for K-wire fixation, ma'am. Reduction and K-wire fixation under CM guidance.
No, which
Open
fracture? Which fracture with the K-wire?
Ma'am, first and second metacarpal, because these both are displaced, ma'am. So third and fourth are not displaced fractures, so we'll conservatively manage, and first and second will go for K-wires, like fixation with the K-wires.
If it is a closed fracture, then
closed fracture also, first and second needs fixation, ma'am, because it is displaced, and we can go for closed reduction and fixation with KYs under CM guidance.
There may be this oblique fracture. We have the rotation component. Then how it will be, managed with the K-wire?
Ma'am, we have to do a cross K-wire, ma'am. To if it is to put a single
Any other
K-wire,
option?
then the rotation.
Any
Now we
other
can put a
option?
plates, ma'am, or the second metacarpal, and we can put a mini plates.
Some
Anatomical.
recent use of some little bit minimally invasive as compared to plates.
Locking compressions.
Screws.
What type of screw?
Locking compression screws.
Hey, what they are called
No,
as?
that is
What type of screw? If
Locking are plates. Screws are some different
plates,
name.
yes, sir. Mono,
It's a called lag screw.
lag screw, yes, sir.
Yes.
you can use lag screw also. You can use intramedullary screws. Like in place of K-wire, you can use a single intramedullary screw. These are very less invasive, very minimal in 0.11 blade incision only. So the reason you can use that. If there is a rotation component also, so the K-wire will not take care of rotation.
Yes, ma'am.
You said closed reduction and K-wire under CM guidance. So when you do an
Yes,
open
ma'am.
reduction also, you want a CM guidance?
No,
Not
ma'am,
required.
not required. Like if you have adequate exposure, no need, ma'am.
Yeah.
In the first fracture, in the first metacarpal fracture, what type of reduction you will give in this patient? Bennett's fracture, something special, you have to reduce.
Ma'am, we have to flex the metacarpal, and with the opposite thumb we have to press the fracture so that the fracture will align on its own, ma'am. Like one has to pull and one has to press the thumb.
You have to extend also, abduct the thumb, extend the thumb. You pronate the thumb, then you have to, fracture will be reduced. It's a specific for the Bennett fracture, not for the others.
Yes, ma'am.
Is there any role for external fixators for fractures of the metacarpal bones?
Yes, ma'am. If it is a severely open fracture, comminuted crust fracture, there we can use a mini X-fix. So that will get to a fracture alignments. Once the soft tissue, everything will be corrected, and there is vascular, everything will be corrected, then we can later on we can go for definitive fracture correction.
Okay. Can we move on to the next spotter then?
Okay, sure.
Over, Rohit?
Yes. Yes, Lakshmi madam, can we move on?
Yeah.
Ma'am, this is a rectangular frame, self-retaining Dingman's retractor with bilateral cheek retractors and
different sizes
of tongue blades and the hockey stick mucoperiosteal elevators in the third picture, ma'am. In the first picture, the rectangular frame has the Kilner's suture carriers. Then it will have the hooks, the hooks which will have two indentation to accommodate the lip and also the alveolar part. And this is the ratchet into which we will fit the tube, mouth, the tongue blades, and bilaterally we will be applying the cheek retractors and we will fix it to how much ever
Nandini, this cheek retractor has some specific, name? Some
Ma'am, it's
specific.
Sommerland. Summerland's
It is a
modification.
universal cheek retractor.
Universal cheek retractor.
Universal cheek retractor.
And tooth blades are there. They have a
Yes, ma'am.
specific
And
use.
there's a hole in between for the ET tube to be seen. And Summerland modified it by removing the flanges that were there laterally in
Only
the.
this much you just tell about the whatever instruments they have shown regarding these only. So what do
Yes,
you think this rectangular frame is different size for the newborn and for the adult with the patient with the palate?
No, ma'am, it
The
is
1
it
month,
is the
3
same.
month old and the adult patient?
It is same size only, ma'am.
Yeah, same size with the
Same
different
size.
blades.
Yes, ma'am.
And what about these third picture?
Ma'am, it is mucoperiosteal elevators, which has a both right side and the left side, ma'am. One side will be a sharp and one side will be a blunt.
Sharp is which side we will place and the concave where?
Sharp will be towards the bone, ma'am, hard palate, and blunt will be over the flaps.
This Dingman mouth gag, any other gag you are aware of in spite of this?
We have a C-shaped Kilner dot mouth gag, ma'am,
What
which have
What is a dot?
C-shaped.
Dot?
It's a modified. Dot is the name of the we have modified. Kilner is the one first
What is the
given.
dot retract mouth gag? Later Kilner dot.
Ma'am, dog is just like it doesn't have any cheek retractors.
They have a Kilner dot has a cheek retractor with it?
No, it will not have cheek retractor. It's only to.
Yeah. What is the Kilner modification?
Kilner is no.
Okay. And what about these rasp? These the third picture. How you use them? When you use these?
To elevate the mucoperiosteal flap. For right side, it have a right side oriented elevator we'll use. For left side oriented elevator
You
we'll
place
use.
in the where you place on the lateral part of the hard palate, from the medial side, from the anterior side, from the posterior side. From the medial.
From the lateral to medial side, we will place from anterior to posterior.
And what is the straight one?
Ma'am, it also kind of mucoperiosteal elevator, which is a sharp.
When you place a Dingman mouth gag, when you place, like after painting and draping, then when you place
Yes,
this
ma'am.
mouth gag, after infiltration, before infiltration, or
after painting and draping, first we will do a tongue stitch, ma'am, and then we'll place the Dingman retractors, and then we'll get adequate exposure of the palate, and then we'll start infiltration and we'll proceed with the surgery.
Okay, you just retract the retractor, and do you anticipate some issue when you fully
yes, ma'am.
place a retractor?
Yeah, we have to keep on asking like anesthesia or anesthesia friend, like whether the airway pressure is maintaining or not. If it is increased, then we have to release the retractor.
Yeah, with the final position, you have to confirm with the anesthetist.
Yes, ma'am.
From these holes, what you see, over the retractor?
We'll see the tube, ma'am.
The
tube have
water
a
vapors that gets collected on the tube, we can see.
With that, what conclusion you get?
If the fog is maintaining, then the airflow is evenly maintained, ma'am.
Yeah.
Dr. Sridevi? Madam? Would you like to ask anything? Dr. Naliappa, sir? Okay. Rohit?
We
you
have
can...
3 to 4 minutes, ma'am.
Okay. Any operative procedures can be discussed along with this. What is the position you maintain?
Ma'am, we have to put a neck in the complete extension
Rose position.
where the eyes see the back wall
Facing
the back wall.
And the palate should
Palate
be
should be
facing the
ceiling.
Yeah.
So
Correct.
we'll place
What
by
type
shoulder.
of tube is used for palate?
We'll use
RAE tube is
South Pole. We'll use.
What is meant by South Pole? RAE?
It's a ring, Adair, and
Elvin.
What is South Pole? That is North Pole?
South Pole will use it for surgeries like palate surgeries, and North Pole, like it is bent towards the chest, ma'am. Like
yeah. What is the advantage?
Like easy.
It will not come in the way of a surgical field, ma'am.
It will maintain. It won't king, and it will maintains the airway pressure also. It is
into the curve, into that curve, the mandible is fit, isn't it? So
yes.
Right. What is the advantage of these springs, Kilner's suture carriers?
Ma'am, for the retraction of the plate, we'll suture carrier, ma'am.
Yeah. Ma'am,
we'll take a suture from the periosteal flaps, and we can
place it over
there, and it helps for retraction.
And it will not help us to keep it in a uniform way, and the entangling of the sutures can be prevented, ma'am.
While elevating the mucoperiosteal flap, when will you stop?
Ma'am,
shall you give medial or lateral incision?
First, we'll do the lateral incision, ma'am.
Lateral incision?
Medial incision is done.
If you give where exactly you give, and medial and lateral where you give, what are the reasons?
Ma'am, medial incision will start. We have to exactly give 2 mm margin or the cleft to leave the 2 mm, and we'll continue up to anterior and
where 2 mm where?
From the cleft margin.
From the cleft margin.
Left margin, there are 2 surfaces, isn't it?
From the
oral mucosal surface, not on the nasal surface.
Yes. Oral side?
Oral side. So we'll continue up to anterior. Then we'll give a lateral incision. We'll start from the maxillary tuberosity. We'll start from there. We'll mark an incision there. And we'll start on towards incision marks towards the anterior. And we'll communicate in the case of burdens.
And what blade you use for the lateral incision?
Ma'am, 15 number blade only we used.
Both.
Except for the uvula, sometimes we can use a 12 number blade, ma'am. Otherwise, here we use 15
only.
15 is for lateral and 11 is for the medial. Okay, from anterior to posterior is the medial, and posterior to anterior is the lateral. Okay, first you always give the medial incision. If you start giving the lateral incision, the bleeding will be there. Okay. So you have to give the medial incision and separate the nasal layer from the palate, from anterior to posterior. Okay. So in that, what instrument you use?
Ma'am, we have a small elevators like mucoperiosteal elevator. We can use a small size of phrase elevator, or we will use a dental scaler, ma'am.
Very good. So after elevating this mucoperiosteal flap, where will you stop and what will you do?
When seeing the pedicle, we'll stop, ma'am, and we'll try for.
Should you stop when seeing the pedicle?
Ma'am?
Not necessary, ma'am.
Should you stop when you see the pedicle? If not, what
we have achieved
the pedicle? And how will it help in movement of the flap? You see the pedicle, what will you do? What will you do?
Ma'am,
Yeah,
we'll
next step you tell. Yes.
we'll skeletonize the pedicle, ma'am, to achieve the
How will you do
movement of
that?
How will you do that?
Ma'am, we'll say the small dental scale or a small elevator, and we'll release the structures around the pedicle. So
So why should you do that?
To get the improved
To gain the movement of the flap
flaps
medially, so that we can close it without tension.
How does it facilitate the movement of the flap? What is the anatomical basis of that?
Once you skeletonize the pedicle, it will get the increase.
No. What is the name of the artery?
Greater palatine artery.
So how does it look? Is it straight or tortuous, or how is it?
No, ma'am. It comes from the palate, and then it will be running all along the palate.
Because it is tortuous, when you skeletonize it, you get an increase in the length
play of
because
the
there is
flap.
an increase in the movement of the flap. So what other maneuvers will you do to bring the flap to the midline?
Ma'am, we'll release the adhesions between the soft palate and the hard palate. That muscle
In the hard palate area itself. You've made an incision, isn't it? Any extensions of the incision you can do?
Like anteriorly, we make it as a unipedicle flap, as in bird axe, ma'am.
Retromolar extension.
Retromolar extension.
Will you start from retromolar region or just?
Mostly we'll
start from the maxillary.
Start from the maxillary tuberosity, ma'am. Retromolar extension we are
Can do.
seeing.
So,
yes, ma'am. Okay.
Yeah, you can score on either side of the vessel also to mobilize. Okay. Next,
Madam,
what is the next step?
Madam, we are exceeding the time limit, ma'am, actually.
Because you told more time, we started asking.
When actually I don't want to stop the discussion.
Yeah. What is the important 3 steps in the palate repair?
Ma'am, to minimize the first is nasal mucosa repair.
Yes.
And oral mucosa repair without tension.
And muscle
repair.
palate. The insertion of the muscles should be dissected, and then
muscle should be oriented properly after dissecting from the hard palate, and
yes, tensionless closure, good
tensionless closure,
and muscle dissection at detachment from the abnormal attachment, and orient in the transverse and posterior plane and suture. Okay, good.
Yes, ma'am.
Yes, ma'am.
Right. We'll go to next session. Yeah.
Complete diagnosis. How will you assess this case?
The complete distance. So complete only assess this case, what are options for management? Actually, the full distance. This is
tripod fracture.
CT scan, CT of the face, CT reconstruction of the face, which gas the zygo from top to bottom. It has a zygo, the ZMZ complete dislocation with pterygomaxillary disjunction, with maxilla fracture, and with
symphysis.
With the symphysis fracture. So entire right side of the face is fracture. Entire the right side of the face is completely disconnected from the
what is your diagnosis? What is your diagnosis complete?
Pan facial, right side pan facial fracture.
Only right side. Only right side.
Is
Only right
side.
Left maxillary.
Left.
Maxillary.
Nasal ethmoid also. Nasal bone is also fractured. Looks like only right side. Left is left also max. Yes, ma'am. Left also zygomatic maxilla fracture is there. Panfacial fracture, ma'am. This patient.
Nasal bone is normal.
No, ma'am. Nasal bone also
Nasal bone
right
is
side.
also fractured.
Right side nasal bone is completely fractured and dislocated.
Left orbit.
Orbit, middle wall of the orbit fracture is there, ma'am. Middle wall of the orbit and middle might be naso-orbital ethmoidal fracture also is there.
Anything more finding which is significant?
Orbital floor, lateral wall of the orbit also looks
That, no, the left side it is fine.
more significant. Leaf out.
Any other
Leaf out
finding?
one. Leaf out one fracture, ma'am, like extending to bilateral sides, and bilateral nasal bone fracture, left side middle all naso-orbito-ethmoidal fractures.
Mandible,
Significant mandible fracture is there. Cranium looks normal. Yes, ma'am.
One finding is missing. There is a palatal it also it looked like to be a palatal split on the this side. Maxillary
yes,
fracture.
ma'am, right side.
Palatal,
How
yes.
you will assess this case?
Ma'am, first general condition we have to see for general condition, ma'am. Like if general condition is fine, if the patient doesn't have any other injury, no polytrauma,
You have to assess, like you have to what all rule. I mean,
airway is
according to ATLS protocol, ma'am.
this is a looks panfacial fracture, ma'am. There is definitely might have airway compromise. So the patient we have to do a tracheostomy.
The plastic surgeons will rule out intracranial use. You think that there is no intracranial injury, there is no other body injury. As far as this facial skeletal X-ray is concerned, what are the things you are going to assess?
So we have to see for first eye vision, ma'am, bilateral because bilateral.
So how do you feel
Yes,
that the
ma'am.
vision will be affected in this from this X-ray?
If the
Perception of light and then finger counting.
And we see the first access for red light, ma'am.
When do you think that the vision will be affected? What are the factors to say? What are the factors to say that this patient doesn't have a vision in the right eye?
Ma'am, orbital floor. If the orbital floor is completely fractured, then patient has a diplopia, and if it is any retroorbital hemorrhage or supraorbital.
Diplopia is different. Blindness is different. See, you said there is a
retroorbital
fractures of the orbit will not cause blindness. What are the bones that are involved in the orbit? On the right side, you can see that almost all the bones are shattered, isn't it?
Yes, ma'am.
And it's a complete. How will you describe the position of the orbit? What is the terminology for that? When there is when both the orbits are not in the same line?
Disjunction.
When the axis is shifted, what do you call that?
Orbital disjunction.
Disjunction, disjunction, dystopia. How do you describe that? Okay, vision you will check. Then what else will you check?
And for the nose, ma'am, we'll check for any internal hematoma, septal hemorrhage, septal hematoma. Sorry.
Apart from hematoma, what else?
Nasal bleeding.
Apart from blood, any clear fluid?
CSF
leak, base of the skull fracture and cribriform flexure fracture. So CSF leak might be there, ma'am.
And then there is palatal split also, ma'am, here, the right side.
So that also might have caused fracture over the base of the skull.
And because there is mandibular right side mandibular like symphyseal fracture also, there if there is any tongue fall there will be massive soft tissue injury also, which can be compromising the airway. So that is the first thing that we will take into consideration. And we will try to secure an airway by doing a tracheostomy or a submental intubation.
Can you do a submental intubation for this patient?
No, ma'am.
Emergency?
We'll go for tracheostomy.
Yeah.
In emergency, tracheostomy will
Tracheostomy will go.
So once the airway is secure, so what is your priority in managing? What is your, how will you manage this fracture?
Ma'am, vision will be the first priority, ma'am. Like if any muscles or extraocular muscles are get entrapped and this thing, so that might consider first. So to prevent the vision
When
loss.
you are talking about vision, don't talk about extraocular muscles first. In this,
if there is any vitreous hemorrhage that is causing
fractures of the optic, you have to think of injury to the optic nerve also, not the ocular muscles first. Because this is almost the whole of the orbit is shattered. You can think of injury, if the vision is not there, you first think of injury to the orbit, to the optic nerve. And then you think, then you talk about the extraocular muscle entrapment. Okay. So if the vision is normal, the next step you will like to think is about the entrapment of the muscles. Okay.
Yes.
And then? So,
and then, so once
this patient. So what is your aim of treatment of this patient apart from airway? And then what else? Entrapment of the muscle. Then
we have to get like align facial face should be aligned, ma'am. Facial symmetry to be maintained. We have to start.
Start from here also there are aspects, both cosmetic and functional. So what are the functional aspects you think about first? You
first
said
we'll
about
for the occlusion.
Entrapment and
occlusion be achieved by IMF.
Occlusion, and then for the airway, you said there is a fracture of the nasal bone also, isn't it?
Yes, ma'am. So nasal
Can
bone.
you correct that? Is it possible to correct that in this patient, nasal bone fractures?
Looks completely shattered, ma'am. Like at first sitting, we'll correct first occlusion, ma'am. Like after vision, first then go for occlusion and nasal. Like if it is any septal hematoma or something, we'll address first. And nasal bone reduction also we can try, ma'am. Like
okay, so this is a case of pan facial fracture where you have upper third, middle third, and the lower third of the face affected. So after you have ensured that the airway is secure, patient is now stable. What will be the sequence of your management? You cannot randomly say, I will go and fix the eye, then I will go to nose and this. So there has to be a plan that out of these three zones which are fractured, what will be the sequence of your stabilization and fixation of these? First, what are you going to do? First, after the patient is stabilized, what is the first thing you're going to do?
So my to bottom top approach I will go, sir.
Bottom to top. So why do you want to do bottom to top? Why do you want to do bottom to top?
So once the occlusion, once the mandible is fixed, then we'll get other bones. We'll take that as a bony landmark, and we'll align the other bones accordingly. We'll align proper. So I'll go for top to bottom to top approach.
Mm-hmm. Okay. So any other reason that you could do bottom to top approach in this case? There could have been a scenario that you will not be possible for you to do the bottom to top approach. Suppose both the condylar fractures were there, the vertical height of the mandible was decreased, then bottom to top approach will not be possible because you have no reference point for the lower third facial height, right? So since in this patient, one side at least the condylar, the ramal height is maintained, so probably bottom to top approach can be done. Okay, so you agreed you want to do bottom to top approach. What will be the first thing you are going to do?
So mandible.
You will apply You will apply an arch bar in the upper and the
Arch
lower
bar
part.
and
No, before that you have to put arch bar.
Yes, sir.
Okay. Okay. So what kind of arch bar will you apply to the maxilla and to the mandible?
So for the mandible, we'll go early arch bar, sir. We can use early arch
Okay.
bar.
And for the maxilla?
So maxilla, right side of the maxilla is completely shattered. So one side of the so for the left side only, we'll still continue with the early arch bar, sir. But
Okay. Okay. So the important thing is that, sometimes when you have so much displacement, if you place the arch bar, you fix it to the teeth, it may not be possible for you to bring them into occlusion. So it helps to divide the arch bar in the center so that you can bring those two segments, which are, now two halves, in center. So you might also benefit by dividing the arch bar. I feel especially in the upper jaw, you might be very, it might help you quite a lot to bring these segments into occlusion. So you have done the IMF now. Now what happens?
Yes, sir.
After that?
After that, we'll fix the mandible, sir.
You will fix the mandible.
Yes.
Okay, why should you fix the mandible first?
So we'll go from bottom to top, so that like lower, like first we'll go from bottom to top, so mandible will be first fixed. It is
Okay, fine.
So
Then
we'll
next, okay, done. Next.
Done. So right side with the upper bulcal incision will go and reduction of the right side of the maxilla and fix the maxilla.
So Nandini, you were telling something about lateral to medial or medial to lateral. What does that mean?
So lateral to medial approach.
What is the meaning of the lateral to medial approach? Because if you fix the maxilla first, then you are committed. Your lateral part of the face is decided. Since there is a fracture of the zygoma, the face is, lateralized. So you should first reduce your zygoma.
Zygoma.
And then after you have reduced that, then this zygoma and the maxillary component will be fixed to its other counterpart so that the facial width is maintained. If you go from medial side to the lateral side, you will end up with the zygomatic system reduced in a lateralized position. So that will not be very helpful. Right? So top to bottom, but when you are going from top to bottom, you start mandible first, and then you go to the lateralmost part of the mid face. Do the zygoma, then you do maxilla. But before doing maxilla, you might also have to do the orbit. If there is something in the orbit, fix that first. And then you do the maxilla, and then do everything else. Then you go to the top.
Yes.
In this
Right?
case, it is important to reduce the palatal split also,
Yes,
because
yes.
there is a widening of the maxilla.
Absolutely.
Initially,
And
you
how
fix
do you?
that.
Yes, that's a good question.
How you fix it?
How do you make it happen?
How do you reduce the palatal split?
With the help of
How about
there's
palatal
instrument
So since
that we
palate,
engage in both the
so since because your palate is now open at anteriorly and posteriorly, so you need to fix it at two places. Anteriorly, you could put a plate here, but posteriorly you put intermolar wiring. You take a wire which goes from one molar to the other molar and comes back. So this intermolar wire then brings those plate segments together. Anteriorly, you have put that plate anteriorly at the level of the incisor teeth, just above that in the peripaphosa area, and that it helps. Putting plates in the palatal bone is very, very difficult. Yeah, Dr. Durga, anything else you wanted to ask about that?
Yeah, that is okay. And then main is the nasoethmoid fracture also there. That is a
Correct.
different entity to correct.
Yes.
That is a different topic. Yeah.
Yes. But I think it is
And what
important
is
for
it?
them to understand the
The
sequencing.
sequence, sequence reduction and immobilization is very important.
Yes, that is very important.
We cannot correct in this patient.
Correct.
Ma'am, can we move to the next topic, ma'am?
Yeah, fine. The question you can have it last.
Stepwise approach period post-operative care and follow-up and discuss. So buccal carcinoma, left side,
Left side into carcinoma, buccal cavity.
might be deep
With
post-stage.
maybe retromandibular involvement, is mandibular, bony involvement with the sinus also.
So one side hemimandibularity maguತ್ತದೆ.
Free fibula.
ಹೇಳ್ತೀಯಾ? ಇಲ್ಲ?
Ma'am, this is a case of left-sided carcinoma of the buccal mucosa with ulceration of
What carcinoma?
stage
What
4.
carcinoma? What is the most common carcinoma?
Squamous cell.
Yeah, completely. Tell it fully.
Squamous cell carcinoma. Looks like there's bony involvement also present, ma'am. So, and then we'll have to assess for the lymph node status also to give the ultimate staging, ma'am. And in this case, how will we counsel? Because it's in by the picture, it looks that the mandibular involvement is also there. So we will first counsel the patient the need for the hemimandibulectomy in this case.
Complete soft tissue excision of the left side and need of hemimandibulectomy also, and the neck dissection also, and possible reconstruction. So
we will accordingly get the investigations done, and then if there is
and prognostic factor also, like if it is a stage 4 disease, patient needs chemotherapy and radiotherapy also. So option for this condition,
would like to go with the free fibula, free tissue transfer.
Free exist with the soft, depend on the defect created, like most probably it will go for hemimandibulectomy. So we have to give a soft both inner lining and outer lining with vascularized
free fibula.
Vascularized bone, like free fibula. Stepwise operative management. So first we'll go operative management. First we'll go for correct thorough investigations. We'll go for CT scan and CT of the face and neck and MRI, and we'll go for endoscopy and video laryngoscopy
in order to rule
out any other primary synchronous primary lesions. And once the staging is complete, once the anesthesia fitness everything done, and we'll counsel the patient and we'll take for operative management with complete excision of the left side buccal left side of the buccal mucosa and cheek, left hemimandibulectomy, and we don't know inside the maxillary extension and retromolar area. So, and neck dissection, and reconstruction can be planned with free fibula, with free osteocutaneous free fibula for the
bipedal osteocutaneous free fibula.
Osteocutaneous for inner lining is cutaneous, and fibula for the bony reconstruction. Outer for the outer reconstruction might do a local petrolis major transfer or a second free flap transfer. Post-operative care, like routine routine microvascular admit in routine microvascular ICU and flap monitoring accordingly. If the flap if for 1 week, if flaps are okay, then we'll go for radiotherapy once the wound is completely healed. Yes,
oral feeding.
Oral feed, like we'll start with the Ryle-Stro feeding. Once the patient all flaps only once come out of the ICU, we can start with oral feeding, and patient will be on tracheostomy also. So Ryle-Stro feeding will be the better. Yes, ma'am.
I invite panelists to ask some questions.
If you are in a center where a microvascular reconstruction is not possible, what will you do?
Ma'am, we'll do a bipedal PMMC, ma'am, for the both inner lining and outer lining. For the bone, for the mandible, we'll use a recon plate to maintain the mandible.
You said PMMC, isn't it? Can you use something else
Yes.
with the PM? What can you do?
We'll do PMMC plus costal cartilage bone also we can use sometimes, ma'am. If you need a bone.
Costal cartilage or rib you want?
Rib, ma'am. Rib, ma'am.
So what are the other options for pedicle flaps for mandible reconstruction?
We can go for PMMC plus DP, deltopectoral flap.
For mandible reconstruction, you said about PMMC and rib, and then any other bone that is available nearby?
Scapular bone we can use, ma'am. Rotate from the back and we can use.
Which part of scapula are you going to use?
Ma'am, lateral.
What is the vascular basis for that?
Thoracodorsal, circumflex scapula.
Which part of scapula are you going to use for mandible reconstruction? Spine of the scapula. So, what is the vascular basis for that? And is it possible in this patient? Is it possible in this patient?
Can
when you have done an extensive neck dissection?
Can be possible, ma'am, but
so what are the other for reconstruction of the cheek? Apart from if you are not planning for a mandible reconstruction, what are the other options you have for reconstruction of the lining and the skin cover?
Pedicle, ma'am.
Yeah, bipedal PMMC, and then
for outer lining we'll use a deltopectoral flap.
Yeah, bipedal PMMC or a single or PMMC with deltopectoral. What are the other flaps?
We can use a supraclavicular flap also for we can use for outer lining.
Supraclavicular flap in this patient? You have done
because
dissection.
Yeah, so supraclavicular artery flap is out of the question. Yes, what other flaps you have?
Trapezius, ma'am.
Is Narayan flap?
Ma'am, scalp flap, bilobed scalp flap.
Based on the?
Based on superficial temporal artery.
Based on both the branches, both anterior and
posterior branches of superficial temporal artery.
Superficial temporal artery. So this flap was described by Narayan, who is from Tamil Nadu, who is an Indian, who is from Tamil Nadu.
For free fibula flap, which artery you will take as a recipient?
Recipient will go for facial artery.
Is it there?
It will not be there.
If it is facial artery, it's not there, we can go for superior thyroid artery.
We would have done a neck dissection also.
Superior thyroid artery will be better.
You will do the ipsilateral or where you will do the anastomosis?
Ipsilateral.
Which side you will take the fibula?
Same side fibula. Actually, for mandible reconstruction, either side we can take, ma'am. Depends on the surgical team. If the surgical oncologist team is operating on the left side, we can take from to avoid this thing at same two-team approach. We can take from right side, otherwise left side also we can take, ma'am. For mandible, there is no side concern, so we can take from either side.
Definitely. And what is your post-operative care in this? I mean, what is the follow-up? What all drugs or anything you will use in the post-op? What is the post-op management?
Post-operative, ma'am, will maintain with the patient in microvascular ICU and patient will be on elective intubation for at least 24 to 48 hours. And we'll give IV fluids and antibiotics and
oral secretion,
or to decrease the oral secretion, glycopyrrolate also we can give.
And then flap monitoring is done. Regular tracheal suctioning should be done.
So yes,
how
long you will
do the flap monitoring?
First 2 hourly for first 48 hours, ma'am. Then 4 hourly for next 2 days, and 6 hourly for next 2 days, and then we will be observing the ward, ma'am, for 1 week. or maximum 8
10
10 days,
days.
and we'll discharge patient if
Sorry
everything
to
if
interrupt
the
you, ma'am.
post-operative file uneventful.
Excuse me, ma'am. I think we are exceeding the time. We can
Okay,
you
fine.
move to the next session, ma'am?
Yeah, can.
With the multiplanar X-fix
Multiplanar fillet.
with one plane, this is
Sorry.
multiplanar X-fix with middle one third soft tissue defect.
With bone also bone defect illa.
I think it's that the X-fix
The
is
X-fix
coming
is
in the
coming
way.
in. So left
It's
or left?
right.
Ah.
This is a case of post-traumatic right-sided middle one-third soft tissue
Composite
soft tissue defect with
exposed tibia
and with
with
multiplanar
fracture stabilized by multiplanar external
X-fix that has been
fixator.
applied.
And yes, ma'am. Without foot dorsiflexion, foot is in the plantar flexion. We could not assess.
And then the X-ray finding.
X-ray.
Mostly there's a bone gap. There's the one limb of the X-fix that's covering it. So cannot exactly comment on the bone status. So in such a case, we will be documenting all the aspect, like what's the mode of the injury. We document like alleged history of so and so a road traffic accident with all the history, followed by the examination findings and the
Any involvement of neurovascular the senses,
vascular status will be
status of
checked. The
injury.
nerve sensory status will all be assessed, and that will be documented, and the X-ray finding about any bone gap that is present, how much of bone loss that is present.
Any bone infection or kind of osteomyelitis or something will be documented. And after thorough debridement, and if no signs of any local any signs of osteomyelitis infection, we'll go for reconstruction. And by the image we can go for a inferior palus transposition flap lateral from lateral medial also lateral both side inferior palus faciocutaneous flambe can be tried first plan. Second plan will be like upper part is also. So inferior palus faciocutaneous flap can be planned, ma'am. So will you document all the aspects? And patient needs further reconstruct till the patient the flap is healed, the X-fix will not be removed. Once the flap is completely
And
healed,
also the bony union has been established.
and we'll remove the external fixator, and we'll ask the orthopedic colleague once the bone is complete, once the flap is completely healed, he can go for a definitive procedure to for the bone fixation, and we can start partial weight bearing after complete orthopedic and our reconstructive procedure. We can go for partial weight bearing, and then
We'll also
complete weight
counsel
bearing.
regarding the bony, the joint stiffness,
Joint stiffness
and the
and
appropriate physiotherapy that will be required.
So what are the options of flap coverage for that area?
In this case, we can plan for, ma'am?
You said inferiorly based faciocutaneous flap. So can you just list out the flap options available in that area?
What are the other options?
No, disconnected.
Oh.
There is some internet issue or something else.
Too much of questioning, madam. That is the reason I think they've left.
Nothing like that, madam. Allowed to answer.
Hey, I must say, both of them were answering questions reasonably well. They were quite okay. They were quite okay. Maybe there is more rain in Delhi. Durga will tell. Maybe.
Not today, but yesterday it was.
Yeah. So it's all over the newspapers. Delhi's roads looking like a lake.
Everything is jammed, within a day.
Yeah.
Within that one day,
Yeah.
everything is flooded.
Sorry to everyone. There's some internet issue.
Yeah.
How come
We
after the
thought
question there is an
we
internet
thought you are in the floods of Delhi now.
Inferiorly based.
Yeah, you are answering so well. Professor Ramesh also told the same thing. So continue answering. You are answering so well.
Yes, ma'am. Sorry, ma'am. Sorry, there is a
Some
internet problem.
internet issue.
And so for this inferior based faciocutaneous flap, either from the medial side or lateral side, we can be planned. Other options, considering we can
You
go
tell,
for
no, you said medial side, lateral. You tell, no, you tell, you only told, isn't it, medial side, lateral side. So what are the options from the medial side? What are the options from the lateral side?
Lateral
Lost him again.
No, sir.
We are here, sir.
Okay.
Perineal based perforator.
We have go for soleus flap also, sir. Soleus flap also, but
you just mentioned what all are the first probability. Options. Can go nahi. You have to tell these are the options.
ma'am, faciocutaneous flap is the option. Locally transposition faciocutaneous flap will be the option. Soleus flap will be the option, and perforator.
So that's what he asked you. Medial side, lateral side. So where are the perforators you are going to base on? Which are the perforators you are going to base on? Medial side, lateral side. Medial side, no perforators on the medial side.
Ma'am, actually,
suggested a very simple
injuries in the
classification. You suggested a simple classification based on the medial side and the lateral side. Medial side, you have perforators. Medial side, you have the soleus muscle.
Yes, ma'am.
And so raise a transposition flap medially, and then laterally.
Laterally, perineal artery based perforator flap can be used.
We can do a inferiorly based faciocutaneous transposition based on the peroneal perforators.
Does it have any name for that? There is any specifically named flap from the lateral side? What are the specific flaps from the lateral side?
Lateral or from the posterior aspect.
Reverse sural artery flap.
And then adjacent territory of the reverse sural.
Supramalleolar flap.
Lateral supramalleolar flap.
Lateral supramalleolar flap.
Then lateral supramalleolar flap is defect.
Not
cover
this defect.
Why? What is the upper limit of supramalleolar flap?
5, 6 and
1 finger.
5 to 6 centimeter above the lateral malleolus only we can take the upper limit of the supramalleolar flap.
And any other flap?
Ma'am, last resort would be a cross leg, but that is like
same leg. From the same leg, any other option? You can have a propeller flap because the medial side skin is almost healthy. It's not a, scarring is not there. You can have a propeller flap.
Propeller flap.
Any other muscle flap apart from soleus? Apart from soleus. Any other muscle flap?
Peroneus brevis muscle flap. Peroneus brevis muscle flap with the graft.
I think another flap which could be tried here from the medial side is you could try one keystone flap. You could identify a perforator, and if there is a perforator, that hotspot you can identify, and then you can have a keystone based flap on the medial side. So this gives you both things. It gives you V2Y advancement, and it makes use of the laxity in the skin. Maybe you might have to graft the area from where the flap has moved. You may not be able to close it primarily. It might be a kind of type 2 flap where you have to graft that area. But then that could also be done because the defect is not very large. You will end up covering this exposed bone there. That can also be a very simple solution to this.
You're interested only in free flaps. What is your choice? First choice. You want to do only a free flap. What is your first choice?
Ma'am, since it is a very small flap, I'll go for opposite limb MSAP.
Medial.
Opposite limb middle solar perforator flap I can go for. The donor side will be closed primarily.
Any muscle flap?
So graceless flap can be used from the same limb or opposite limb also, ma'am, as with the grafting.
Graceless myocutaneous or muscle flap?
Muscle flap. We can take myocutaneous, but that skin paddle over that will be like it is not constant, ma'am. So
may not be reliable. May not be reliable skin paddle.
Yes.
Graceless myocutaneous or graceless muscle flap, which is easier to raise?
Muscle flap.
Graceless muscle flap is easier.
Great. Good.
Madam, can we move on to the next part of the program?
Last session, madam. So
Yeah.
they have completed all sessions very well. They nicely answered. So any questions from delegates or other faculty, they can ask. Otherwise, panelists can analyze the presentation and supplement the suggestions. Sir, Dr. Ramesh Kumar, sir.
Yeah. As I have already said that I was away for about 10 minutes to attend a meeting. So barring that, whatever I have seen, I think they have performed quite well. My only comment is that many times when you have been told to speak about a particular thing only, so speak about that. Like when they were discussing about the postbone contractures, so they were hovering on to the other contractures again and again, and they had to be roped back to neck contracture and the dip contracture. So I think that focus has to be there while they are discussing. Other than that, I find them quite okay.
Thank you, sir.
Thank you.
Thank you, sir. Dr. Sridevi, madam.
Madam, both of them, first of all, I think I should congratulate all the participants, all the teams. I think this is like a reality show in running in TVs across all.
That's a good one. That's a good one.
So I also tell my daughter is a very good singer, but I'll tell her it's you must be very courageous to go and participate in a reality show because you need lots of guts to be appear on the stage on the TV. So I really appreciate all the participants for taking this initiative and presenting very boldly, and both of them did a very good job. And of course, as far as plastic surgery is concerned or any medical field, we have to keep on studying till the end. So this is only a beginning for you. So don't be unhappy about questions you have not answered. This is only a learning platform for you. So definitely have done a good job, and you can continue studying. And even after you get your degree, also continue studying. That's my advice as a teacher for you.
Yeah.
And
learning never stops. Learning never stops.
And I'll take this opportunity to sincerely appreciate the efforts of Dr. Lakshmi also. She has taken so much effort to organize this. My sincere appreciation for her. Thank you so much for inviting me, and I'm so happy and privileged to be part of your team. Thank you, madam.
Thank you, madam. Thank you very
You know, I must also admit that Dr. Lakshmi is a go-getter. She will be after you till you give your best.
Thank you, sir. Thank you very much.
Dr. Lakshmi, can I have a question?
Yes, sir. Yes, sir.
Well, you both, twins from AIMS Delhi, has done nice and with the guidance of Professor Singhal. In fact, I am just a little out of syllabus because I am not supposed to ask questions like Professor Sharma and Madam Sridevi and others. In fact, what is Professor R.L. Thatte's method of reconstruction of flaps in case of external fixators?
Venus flap.
It has come up in the British Journal of Plastic Surgery also. You know or not? You tell no if you don't know. If it is, I told no.
Sir, not relevant.
You're marking.
Venous flaps, sir.
No, I am not asking. This case, what you saw in the last case, there is a compound defect, bone fracture is exposed, and you are going to reconstruct. And in that process of reconstruction, you might have a problem of having the flap to be processed in transposition. So what other method he has devised where you can fix up the flap also with the fixator, with fixator will be there, but some procedure has to be changed in the fixator.
Sure about it, sir.
Well, Professor Thatte has devised that you remove the pins. Temporarily, you remove the pins on the table and you do your procedure. Then you put up the pins in the holes. So that after the transposition, the pin, the 10-man pin, or whatever pin has been put into the bone, can be reapplied again. So this has been done by Professor R.L. Thatte from Sion Medical College, Loknayak Medical College and Hospital, Sion Hospital. So this has come in British Journal of Plastic Surgery long back. So that's why I told it is not a very recent thing, so which you know. But one must know in situations where you are not able to give a flap, you can remove the pins, put up the flap in the proper way, then you can put up the pin or reapply the pin again. You understood this?
Okay. Yes, sir. Thank you, sir.
I invite Dr. Durga madam to.
Yeah. Good evening. Both of them have done a very good job. They have a good knowledge, and they worked hard for this, and they have an excellent presentation. But I'll tell you one thing, like in the history, you should include chief complaints. I mean, at least you should, which are obvious for the patient. Even, like in this case, you told only the patient has difficulty in seeing up. So which is with the severe contracture, you should take care of all these things because chief complaints are very important. Even if you have explained in the history of present illness, but the chief complaints are very important to, present. And the thing is that the diagnosis, you should have a proper diagnosis, like you should not include each and every positive finding in the diagnosis. But diagnosis should convey that, it's like what is the main diagnosis and the associated main complaints. It's not like negative. You keep on telling facial. If there is a hemifacial microsomia, you will keep telling with the microtia, with the absence of facial nerve normal and all these. You should not enumerate like a leg defect without this deficit, without this deficit. You have to have a diagnosis. Like in this patient, you have to mention about the PVC involving the neck and the lower face because the scarring is very obvious. You have to mention hypertrophic scarring. But the prominent, only with the PVC neck, it is not adequate in these patients. And keep on telling the positive finding is also, not good for the diagnosis. So diagnosis should be crisp and it should not be a lengthy diagnosis. Third is like in the X-ray, which in this case, pan-facial, you should, from the one point, like from the left side of the mandible, right side, then keep on seeing the maxilla, intraorbital, supraorbital. Then you go to the maxilla, pyriform fossa. Everything you have to look up. In this patient, you miss the palatal split, which is very important. If you go from one side, you will not miss anything. Either you go from below up or from above. And similarly, you have to see the whether there is this in patients with the TMJ. Very important. See the coronoid process also. I'm just telling because OPG is there. You have to go from the mandible, from the sigmoid notch, from the condyle, from the coronoid, everything just by seeing like there is a prominence of the in this case a zygomaticomaxillary complex. Zygoma is almost dislocated, fractured and dislocated. So by the prominent feature, you cannot, just jump on the diagnosis. You go from one side, either from the below, a whole component of the maxilla, then mandible, and then orbits, then you will not miss anything. So whether the instruments or X-ray, you go from one side and you complete, similarly in the hand X-ray, you see the bony structure, you see the joints, you see each and everything. Like if there is a prominent metacarpal fracture, then you don't miss the other phalangeal fractures or something like that. So these are the important things. And one important thing in the like treatment is you have to tell the options. You should not say like this may be done, this flap can be done. No, only my options are first, second, third, fourth are these. Can be done. You have to like I will do this. I will do this. I will do this is my first, this is my second, this is my third. You take few minutes. It is not that you have to speak within a minute or so. You take time, you take 5-10 minutes, and then you just summarize what I have to see. I can do this flap, I can do that flap. No, you have to give the options, and accordingly you explain which are the best options and which is the rare. If they will keep on asking, then there is a different like. If they are asking any more, then okay. Otherwise, you should have 3 options made. And if there is a like defect or something like that, and you have not seen any microvascular, then you can, give a favor points and you can explain the pedicle flaps also. Like if you have not seen that flap and keep on, describing a microvascular which you have not seen, and the flap which you are very much confident about the steps and about the flap, then you can give a points in favor and you can, go with that option. This is also some patient, some children, what they do, they have not seen that microvascular flap, and the local pedicle is also very important. It's a good option, but they thought ki, first I will tell the microvascular, and they are not very much, they have no confidence, neither they have seen. So it should be very clear that whatever you see in the wards, and you have to tell only those things, you keep on reading in the journals and in the books, and then you describe those very atypical options. So you should, avoid all these, whatever you have seen in the wards, or if you have not seen, then you can describe which option is better. So always, examiner go with the what you have experience in your wards or what your center is doing, and this should have points in favor and points again. That is my, sometimes they have a very irrelevant answer, but these kids, they have done very well. And, it's I must say all the best for the future and for your next activity or the exams. Very nice.
Thank you. Thank you.
Thank you, Dr. Durga. I
Thank
request.
you. Good evening. Both candidates did extremely well, ma'am. Really, in both case discussion as well as the instruments and asking and everywhere. And of course, as already mentioned by my colleague in Stanley, Dr. Sritavi and Karki Madam, everybody else were too practical also. For example, in one question, our Sritavi Madam was asking if it is not in a center where a microvascular is not available. Like that.
You please
Hello? Hello?
Yeah.
So in that type of questions also, they were able to answer very boldly also. Of course, they are from the apex center of our country. They are from the topmost. However, they were able to see they were able to say all the medical flaps and all those things also. And history also, in the long question, as told by our Karkil madam, a few things we must particularly mention about the chief complaints, whether you must anticipate whether the patients are telling for that or not. As told, such a broad contracture, you told a band-like contractures. It is not a band-like contracture. Even though it's comprises of many bands, now it's a broad contracture. These are all the smaller things. By doing practice, certainly we will we will avoid even this minor thing. Even the real examination, after a long case presentation, you have got a small break. And okay, but here there is no break at all. Continuously for 3 hours, both of you as a single unit, continuously 3 years, you are able to answer very well. One by one, you very well answered. And your other competitors from other teams, questions were also excellent, except one or two questions which were very particular about theory discussion. All questions that is also were very practical for you, and you answered most of the questions in a very nice way. Everything went very well. All the best for all of you. My best wishes. I congratulate our Lakshmi madam for having taken so much interest upon our country's postgraduates, not only on her institute, and the entire country's postgraduates, and really dedicated madam. For one day having sitting for 3 hours, many of us find little difficult, but 2 days in a week and years together preparation, really hats off to Lakshmi madam. Thank you for all giving this opportunity. Thank you very much.
Thank you very much.
Thank you, sir.
Yeah. Madam, I'll say one thing, like this Plastiquest platform is very good for the postgraduate. At our times, this type of things were not there. But at present, it's a very good platform for the postgraduates, and to have, from the inputs from all part of the body, not only from their center and other centers. So because they have to face various exams in every part of the country. So I think, a lot of hard work from Madam, you and your team, and it's a very successful, program and quiz. So congratulations to you and your team.
Thank you, madam. Actually, there is a very good support from all the faculty, and even the PGs are with small instructions. They are very nicely preparing. Actually, I'm very happy that you all are cooperating. That's why I tell the Plastiquest is not just a platform, it is a family. So we are helping each other. And as you said, yes, my intention is we are working very hardly when compared to the all other professions. What we gained from our institutes is very variable across the country, and the knowledge has to be distributed and shared, and our future generation should get the benefit of various people. So with that intention, we have started this Plastiquest, and it is continuing because of the support of all faculty and PGs across the country. And they are also very putting lot of effort to participate. If you see the participants throughout the session of 3.5 hours or 4 hours, it is more than 100 participants. And I thank all of you for accepting to participate in this program and contribute your experience and share your knowledge. And Dr. Durga ma'am and Dr. Aditya Agrawal sir has contributed, shared their clinical material also for future sessions. I thank them from bottom of my heart for behalf of the Plastiquest team. I request, this is the end of the session, and tomorrow we'll have the session 6. I request Dr. Likita to give the vote of thanks. and special.
Madam, you are a truly national teacher, national professor.
Sir.
Yes, ma'am.
Sir, in
You are
front of
truly a national professor.
Dr. Ramesh Kumar Sharma, sir, you are telling he is a legend and great figures, and I'm nothing in front of all of you. So we all together teaching our students.
And in a lighter note, I think today World Cup is there. Let us have best of luck for our Indian team.
Yes, sir. And today the team has performed extraordinarily. From the beginning till end, everything they answered. As the panelists suggested, if you incorporate and go a little systematic way, as Durga told in PBC, the activities of daily living, always you have to tell in contractures, post-burn contractures, and systematic examination of the how you do come from supraorbital and nasal bones, orbits, maxilla, mandible, palate, like that. If you go one by one, you don't miss anything. But even then, you have done very well. You didn't miss much. So wish you all the best for your finals. Like
Thank you, ma'am.
in life also.
Thank you.
Dr.
Thank you,
Likita?
ma'am.
Yes, ma'am. I'll keep the vote of thank you short. It's my privilege to thank Dr. V. Bhattacharya sir for his guidance and support. He's our overall mentor. We also would like to thank our overseas sponsor, Dr. Venkatratnam sir, for his belief in this cause and for constantly supporting and guiding us. A very special thanks to Lakshmi ma'am for being the mentor, for being the organizer, and also for her constant commitment and support throughout this process. And also from a special thanks to our other organizers, including Dr. Sandeep Vijay Raghavan sir, Radhakrishnan sir, Umar Farooq Baba sir, for always being there, and behind the scenes, they always take care of everything. Our co-organizers and PG mentors, Dr. Rohit, Dr. Sania, and PG mentors, including Dr. Srivalli, Dr. Sandeep, Ajo, and Swati, they take care of most of the behind the scenes work with ma'am's guidance. My special gratitude to all our panelists, including Ramesh Kumar sir, Sridevi ma'am, Durga Karki ma'am, and Nalipar sir, for spending so much time and for giving such beautiful inputs. Our special thanks to our judges who have spared so much time every week and taking care of this humongous task of judging this wonderful sessions. My special gratitude to Durga Karki ma'am and Aditya Agarwal sir for giving pictures and the imaging for future sessions. I also thank our today's PG students, Nandini and from AIMS Delhi, for their participation, and all other students who have been very enthusiastic and have answered all their questions. And last but not least, I would like to thank all the participants for staying back till the end of the session. And I hope all of you get to watch the match today.
And join back to Plastiquest tomorrow at 4 o'clock.
Thank you,
Thank you,
madam.
ma'am.
Thank you, sir. Thank you.
Thank you,
very
sir.
much. Thank you.
Thank you very much to all.
Thank you so much.
Thank you. Thank you. Thank you, ma'am.
Thank you, sir. Thank you very much.